Well, hello. Good afternoon and welcome back post-lunch. A healthy lunch, indeed. I was allowed to eat unsupervised. All right, so we'll get started off with our afternoon portion of the session. And this will be about genetics and family risk. So we're really excited to have Dr. Nicholas Borgia coming to speak with us. He's a medical geneticist and we'll be talking about genetics and family risk with us. Thanks.
Okay, thank you for having me today. As was mentioned, I'm Nick Borja. I'm a medical geneticist here at the University of Miami and Sylvester Comprehensive Cancer Center. And my clinical focus and research focus is on hereditary cancer susceptibility. So today we're going to talk about the genetics of uveal melanoma from an inherited risk perspective, what we know, what we're still trying to figure out, and hopefully answer any questions that you have today. So obligatory introductory slide. As you all know, uveal melanoma is the most common intraocular cancer in adults, but quite rare, with an annual incidence of 5 per million cases. And it arises from the melanocytes of the uveal tract, most commonly in the choroid. One of the interesting features of uveal melanoma is that it is, from a genetics perspective, quite distinct from cutaneous melanoma with regard to the genetics that drive the cancer biology and also the treatment options associated with the cancer. Key uveal melanoma risk factors are listed here. I included a picture of the famous neurologist, Dr. Oliver Sacks, who had uveal melanoma, diagnosed it in his 70s, and he wrote very beautifully about that diagnosis in a book called The Mind's Eye. In any case, he, to some degree, represents some of the physical characteristics that we associate with uveal melanoma risk. So Northern European, light skin, sensitivity to sunburns, light iris color. Of course, there's also family history of cutaneous melanoma and uveal melanoma that suggests an increased risk among individuals who have those factors. The dominant paradigm in inherited genetics of disease is rare genetic risk factors that confer a significantly elevated risk for developing cancer. So this is a little diagram that I made to represent how we receive half of our genetic information from our mother and then the other half from our father. And we have 2 copies of every gene. And genes, as you all know, are the instructions for our cells on how to behave. So our eye cells have very different functions, obviously, from our kidney cells or our heart cells. And that behavior, those functions, are in large part directed by the genetic material within the cells. And so if we inherit a genetic variant, sometimes I'll call them pathogenic variants, sometimes I'll call them mutations, but in any case, if we inherit a genetic change that prevents that gene from working appropriately, then we are at increased risk for developing cancer. That genetic variant doesn't necessarily mean that we will develop a specific cancer, but it does significantly increase the risk. And as you all may know, BAP1 is far and away the strongest gene associated with uveal melanoma risk. So the BAP1 enzyme has a very important role with regard to cell differentiation, DNA damage repair, cell proliferation. So in taking that role, when we lose one working copy of BAP1, we still have the backup copy that's functioning appropriately, but that sets up our cells to be at an increased risk for losing the second copy. And it's typically when we lose that second copy, which may only occur in a small percentage of cells, that cell population can then go on to develop cancer. So again, we typically only inherit one copy that's not working, but that second copy then takes on the lion's share of the duties, and we're vulnerable to that second copy being lost. So interestingly, in large unselected cohorts of uveal melanoma patients, we find only about 2 to 4% of patients have a germline pathogenic variant, a mutation that they've inherited in BAP1, suggesting that in unselected patients, it's a relatively uncommon risk factor for developing uveal melanoma. But then when we look at cases where there's not just a personal history of uveal melanoma, but then a strong family history, that rate goes up to around 20%. So a fifth of patients have an inherited BAP1 mutation. And one thing I think I should clarify, because I'm sure we've been talking about BAP1 in the context of also tumor initiation and progression. BAP1 is commonly seen in uveal melanoma. That doesn't mean that it's necessarily a genetic cause that predisposed to developing the melanoma. So BAP1 is very commonly mutated in uveal melanoma. Much less commonly is it something that we inherited and driving that melanoma risk. So I just want to clarify that. And the cancer spectra associated with BAP1 syndrome is quite varied, actually. So we typically think about uveal melanoma as well as mesothelioma. There are a range of different cancers that can occur. And so uveal melanoma is by far the most common cancer associated with BAP1, occurring in 36% of cases. And there are some other features that call our attention. One is that it typically is the case that uveal melanoma occurs in individuals who have an inherited BAP1 mutation at an earlier age, and also that uveal melanoma tends to be more aggressive. The most common tumor associated with the BAP1 syndrome is actually atypical Spitz tumors, which are called BIMTs, not exactly rolling off the tongue, but stands for BAP inactivated melanocytic tumors. So other cancers that can occur in the syndrome are peritoneal and pleural mesothelioma, renal cell carcinoma, basal cell cancer, cholangiocarcinoma, and then of course cutaneous melanoma. And the overall lifetime risk of developing at least one malignancy in association with this BAP1 tumor syndrome is about 85%, though there are reasons to think that this is an overestimate due to ascertainment bias. So we tend to see when we're studying BAP1, we tend to be studying the most severe cases because they're the ones that are coming to our clinics. They're the ones that are seeking medical care. And it may be the case that there are less affected families that never come to clinical attention. So this is a pedigree, which is essentially just an illustration of the family history of a patient that we saw in clinic with BAP1 inherited cancer susceptibility. So the circles represent females, the squares represent males, and the lines represent how they're connected within the family. So the patient that we saw is an 81-year-old female, and our genetic testing identified that she did in fact have an inherited mutation in BAP1. Her cancer history is notable for a lung adenocarcinoma at age 71. So not one of the cancers we typically think of in association with BAP1. And then uveal melanoma diagnosed a year later in her right eye. And she had a father who developed uveal melanoma at age 60, as well as a sister with mesothelioma diagnosed at age 61, and a niece who developed a meningioma that was diagnosed at age 32. So this is one way a family can present, but these hereditary cancer syndromes, including BAP1, have a feature known as variable expressivity, which means that from family to family, we can see a lot of differences. And so we look for specific patterns, but those may not always be particularly clear or obvious. As far as other genes that may confer uveal melanoma risk, MBD4 is the new kid on the block to some degree. And this is a gene that when you inherit biallelic, or you inherit a mutation from both mom and dad that lead to a loss of function, you're at risk for a very rare cancer syndrome that involves uveal melanoma, colon polyps, leukemia. But what we found is that individuals who have just one copy of MBD4 that's affected are at a significantly increased risk for developing uveal melanoma. So in unselected cases, the rate is about 1%, so a lower rate than the rate of BAP1 in unselected uveal melanoma cases, but significantly enriched in the uveal melanoma population. And another interesting fact that has led investigators to feel confident that this is driving uveal melanoma risk is that we typically, in patients that have this specific inherited mutation, we see a characteristic mutational signature in the tumor. And that is MBD4, kind of like BAP1, is involved in DNA damage repair, a specific type of DNA damage repair called base excision repair. And as a result of that, we see a hypermutated phenotype in the tumor itself. Again, although this is a relatively newly discovered cause of uveal melanoma risk, we believe that that's some corroborating information suggesting that this is really affecting uveal melanoma risk. Interesting, unlike BAP1, we don't see individuals develop early onset uveal melanoma in association with MBD4, unlike BAP1. So now the question that we have to answer is, what other causes of uveal melanoma exist? And in large-scale exome sequencing cohorts, they have found that uveal melanoma patients can oftentimes have other hereditary cancer syndromes that we don't typically associate with uveal melanoma. And part of the challenge is understanding, are these incidental findings that bear no relationship to the uveal melanoma diagnosis, or do they cause uveal melanoma risk in a small percentage of patients? And if they do, why in just a small select group of patients? Some of these syndromes are associated with hereditary breast and ovarian cancer, very well understood and well studied amongst thousands and thousands of patients. Similarly, some of the mutations are associated with Lynch syndrome, which is a colon and uterine cancer susceptibility syndrome. So we're not quite sure. It may be the case that there are other environmental and other genetic factors interacting with these hereditary cancer syndromes, conferring additional risk. So that's something that remains to some degree unknown and subject of debate in the genetics community. So there are other genetic risk factors. I mentioned at the beginning that our dominant paradigm is single rare genetic variant conferring an outsized risk for a specific cancer or specific group of cancers. But it's also the case that we know there are common variants distributed across our genome that add small or decrease by small amounts our risk. I'm talking about like decrease by 0.1%. These factors, however, can add up to significantly modify our risk. If you imagine a bell curve, the way we think of height being determined by a bunch of different genetic factors, they can all combine to create kind of outliers in one direction or the other. So this isn't clinically validated at this point, but I think it's worth mentioning at least that some of these studies that have been done analyzing uveal melanoma patients suggest that there are additional risk factors that may explain the occurrence of uveal melanoma in some families. One of the things that's interesting is that some of the places where we find these risk factors within our genome are in pigmentation genes, which we talked about earlier are some of the physical attributes that we may identify as being associated with uveal melanoma risk. So that may be a partial explanation for why we see that relationship. And the NCCN, which is the National Comprehensive Cancer Network, it's a group of the most august oncology centers across the country. They meet and develop guidelines on who needs genetic testing to determine whether or not they may have a variant in BAP1, for instance. And they use the criteria that we would expect. Do individuals have an early onset uveal melanoma that's particularly aggressive? Is the uveal melanoma bilateral, multifocal? Are there a personal history of other cancers that would be consistent with uveal melanoma, like cholangiocarcinoma, for instance, or renal cell carcinoma? And then is there a family history suggestive of another hereditary cancer syndrome that could be involved or could at least be a partial cause of the cancer risk? To be frank, I'm not completely given to following the guidelines around who we test for uveal melanoma risk. I personally believe that we should be testing very broadly, especially in a center like this one where we have the resources to offer the appropriate counseling, assuming the individual wants that. One of the reasons for that is cases like this. This is a patient that I saw just a couple of months ago. He's a 52-year-old male with a new diagnosis of peritoneal mesothelioma, no family history whatsoever. This pedigree is a little bit more difficult to read, but you'll have to take my word that there's no family members who have a history of cancer to the best of his knowledge. One of the limitations in using family history as a criteria is that many times individuals don't know the family history. They're disconnected from their family members. This individual had moved from Honduras at an early age. He knew very little about his paternal family members. Another challenge is that many hereditary cancer syndromes, BAP1 included, occur de novo. What de novo means is from scratch. In other words, the mutation doesn't come from the parent per se, but occurs spontaneously in either the egg or sperm cells. So there's no family history because there's no family member who has ever had that mutation before. So that's something that, keeps us awake at night sometimes when we rely too much on family history to decide who does and doesn't get genetic testing. So this individual was only caught because they did sequencing of the tumor. They saw the BAP1 mutation at a high allele frequency, suggesting that it may have been inherited because it was so abundant in the tumor cells. And of course, we went on and did genetic testing and found that that was indeed the case. So, fortunately, in this case, the individual has children and grandchildren, and so those family members will all benefit from him having been identified. So, my plug for hereditary cancer testing is that it's easy. Generally speaking, it's very cost effective. Even for individuals who don't necessarily meet guidelines, it's often covered by health insurance, at least partially. Oftentimes we can get a $10 copay or a max $100 out-of-pocket cost, which is much cheaper than it used to be. Oftentimes saliva or cheek swab is enough to get a high quality sample for sequencing, and results are available pretty quickly after testing is done, usually about 3 to 4 weeks. And the real goal behind doing genetic testing isn't just to answer the why question, though for some individuals, that's a strong driver for doing the genetic testing. But more importantly, I think it's to be able to offer more precise surveillance and risk-reducing interventions, to test other family members, to know who else in the family is at risk and isn't at risk, so that those who do have an increased risk receive the screening that they need, and those who don't have an increased risk aren't asked to go through all of the screening that may be medically unnecessary. Just to give you, since we're talking so much about BAP1 today, an example of what kind of surveillance we do for individuals who have an inherited variant in BAP1. We offer or we send them to ophthalmology for dilated eye exams, and our guidelines suggest that should be done somewhere between ages 11 and 16. So typically at 11 if we can. We send them to dermatology where they get annual full body exams, biopsy of any suspicious lesions starting at age 18. And then we surveil the intra-abdominal and intrathoracic organs, given the risk for pleural and peritoneal mesothelioma, as well as the renal cell cancer, the cholangiocarcinoma. And those are done with alternating ultrasounds and MRIs annually. So that's one of the ways we try to mitigate the risk is by identifying cancer in the earliest stages. I think we all know that identifying cancer early versus late portends very different outcomes. And so that's the strong motivation behind this kind of surveillance. And we're very fortunate at Sylvester to have hereditary cancer testing that can be done through a range of different clinics that are staffed by genetic counselors as well as nurse practitioners. We have the benefit of being able to offer counseling both before and after testing, because it's not just about the result. We want to make sure that individuals who undergo testing are prepared to receive the information, and that afterwards we make sure that it's as actionable as possible. And we're continuing to investigate unsolved cases. So this is a patient that I saw last year. She's a 73-year-old woman with a history of breast cancer, followed by uveal melanoma and then mesothelioma. So, of course, when she came to clinic, we suspected that she would test positive for BAP1. We offered her testing in 2023 that was negative, and then she came back in 2025. We did expanded testing that was again negative. And just to harken back to what I mentioned, the positivity rate is for individuals who have a personal and family history of uveal melanoma, it's still only a fifth of patients. So I believe it's very likely that there are strong genetic risk factors that are rare, but important drivers of cancer risk. And, this patient, potentially one of such patients. So I have a research study called TRACE, which stands for the Targeted Research and Analysis of Cancer Etiologies. We're always looking for fun acronyms. So that's how I came up with that one. And the goal of this study is to investigate through analyzing research grade genome sequencing of both tumor and normal samples to try to identify new genetic contributors to cancer risk, including uveal melanoma. So we have been going strong for the past year and a half and enrolling participants in that study. So that's one of the ways we're collaborating with our oncologists and other specialists. So with that, thank you very much for your attention.
I'm curious on one of your early slides. Okay. One of your early slides had BAP1 skin related things with little dome shape things.
The atypical.
Are those just something that happens when you have BAP1 and they're non-threatening, or is it something that shows up that you have to worry about?
Yeah, they're considered benign, kind of pre-cutaneous melanoma type lesions, but they are considered benign. They're essentially like plaques or papules that are flesh colored, and don't necessarily portend a strong health risk, but when they're seen, that's another potential clue, because remember, about 72% of patients with BAP1 have them. So in individuals who have many of those, that could be a sign. And oftentimes a dermatologist will biopsy those, and when they come back with an atypical Spitz tumor, they'll get referred to us for BAP1 testing for that reason.
I had a nucleation a year and a half ago, and after that whole process, I had genetic testing done at the Cleveland Clinic, and they didn't see uveal melanoma in my offspring or potential in my offspring.
Yeah.
But they did see ovarian cancer as a potential.
Okay.
And so they recommended that my daughter, who's 39 now, 3 children, once she reaches the age of not having children anymore, have her ovaries removed. Like how does that come? How does that process work? And why is there other cancers that will be identified that you have some other treatment or
Yeah.
prediction?
Yeah, so that's a really good question. So when we do genetic testing, we typically, my preference is to do broad testing because that happens sometimes. I assume they were testing you thinking, okay, maybe we'll find BAP1, but what probably came back positive is something like BRIP1 or, another gene that confers increased risk for specifically ovarian cancer, RAD51C, what have you. And there are many genes that do. And so that was identified incidentally because we're not sure, as I showed earlier, we're not sure that RAD51C increases the risk of uveal melanoma. It might, but probably not. But in any case, it was incidentally identified. And the benefit of that is we know, okay, she's at increased risk for ovarian cancer. So because it's very difficult to screen for ovarian cancer effectively, and when it presents in late stage, it's a very deadly diagnosis. The recommendation in those cases, when the lifetime risk of ovarian cancer is above 5%, is to remove your ovaries. So. Exactly. That's exactly what you would want to do. So again, a tremendous health benefit to your family that was not at all related to the reason you got genetic testing. And I think that's why in the future, we're going to be doing this at a population level because, we know that geneticists and oncologists and so forth, we're very bad at predicting who's going to test positive and negative. We're only right about the sensitivity of our guidelines-based testing. The NCCN testing is about 50%. So half of the cases we're missing. And, obviously there are risks to overscreening as well. I don't want to be, I don't want to necessarily ignore those, but I think, or I hope in the future that we're doing this much more broadly.
Hi, yeah, sorry. So I know you said you're still looking for patterns in the testing, but do you find that it's more likely to be hereditary from a male or a female side, like from the X or Y chromosome in terms of BAP1?
Good question. No, we don't see that pattern. So we're, both of our parents have, the BAP1 gene. 2 copies, as I mentioned, everyone has 2 copies of every gene. And so with BAP1, we don't get to pick which copy we inherit from either parent. It's a 50-50. And same with us passing on our genes, 50-50 with each child independent. So of the prior children. So it's just a coin flip, unfortunately.
Okay. Second question. So obviously as a society in terms of pregnancies, we're finding that that's occurring later and later. And you said that BAP1 can sometimes not be hereditary, but it can occur in the egg or sperm. So are we finding that with the fact that DNA reparations are kind of declining as we find like later pregnancies? Are you finding that there's an increase in uveal melanoma or stuff like that? Or those mutations later on?
That's actually that's a very nice question. So in particular for, as you may know, advanced maternal age increases the risk of non-disjunction events, which increases the risk for things like Down syndrome. With advanced paternal age, which we define as over 45, but the risk starts increasing after 40, there's an increased rate of these de novo mutations. So yes, we see we see that across, not just with hereditary cancer. Hereditary cancer, we don't see as strong a signal because most hereditary cancer is inherited. It doesn't occur de novo in most cases, but many of the genetic causes of things like intellectual disability, other complex syndromes are affected by advanced paternal age. So yeah.
Dr. Sabula, I saw your name or your group's name on like maybe 50% of the papers presented. I wanted to give you an opportunity to comment if you had additional thoughts.
Yeah.
Oh, thanks a lot. So I thought Dr. Borja did an awesome job. I mean, this talk was fantastic, and he just represented the literature so nicely. And I mean, this is such an important area. So I think our goal is that if we can find people who are at risk for this type of cancer, we can catch it early and maybe even prevent it. So that's sort of our whole goal. And I think I just applaud you, and we're so excited about it. So I think what we're doing at Ohio State, so we've taken this, so we helped identify the VAP1 tumor predisposition syndrome. And so we are following we have about 100 patients that are part, we have actually a registry, like natural history study that people can just join if they have VAP1. And these are people that may or may not have any cancer in their whole family. And so what we do is we actually will see patients at Ohio State and follow them with specific testing to try to see if we can detect cancer early for the type of cancers that they're susceptible to. And we've already had some really exciting results where we've been successful at detecting cancer really early. One guy, we saw him, we found an atypical freckle on his iris, but the next time we went to check his iris, he actually had a new basal cell carcinoma on his eyelid. So that was managed really well. We had another patient where we found a meningioma in her spinal cord area. And then we found another patient with a mesothelioma. So by screening, I think we're going to really hopefully be able to impact patient outcomes.
Final question?
Sorry, 23andMe and Ancestry and all these things, they're putting genetic information out there. Have you had people come in and found that they're at risk for whatever, and you do further testing and discover more stuff, or how's that been going?
So I think like 23andMe doesn't quite look at those type of genes, but there are some, more patient, like, I forget, I'm blanking on the name now, but
Like
maybe
Nebula,
yeah,
genomics. Yeah, there's some direct to consumer
population-based ones that I think are really important.
Yeah, and like sometimes we'll get a patient referred to us from the All of Us study, for instance.
That's it.
So yeah, it does come up every once in a while. 23andMe doesn't, that's not
helpful.
Yeah,
For this, yeah.
A quick question. For patients with a germline variant in BAP1 and an inherited variant, when they develop uveal melanoma, do they still require the G alpha coupled hit initially, the GNAC and GNA11, or is that bypassed and these are mutually exclusive? Do we know anything about that? That's number one. Number two is any work on PARP inhibition of prevention in these germline variants, given the mechanism of how BAP1 actually works?
Yeah, I don't know the answer to your first question. It's a very good one, but I don't know the answer. With regard to PARP inhibitors for prevention, that has, to the best of my knowledge, there aren't any active trials looking at that. I've heard discussion of that, but generally speaking, cancer predisposition, because the penetrance for many of these syndromes is low. Obviously for BAP1, it's on the higher end, 85% lifetime risk is, we would consider high. But because of that, there has been hesitancy to commit someone to any, treatment, even when the side effects are manageable due to that risk. So.
Fantastic. What an excellent talk. Much appreciated and great discussion. I wanted to make one super fast point. When we were in the ISOO meeting, Amy Scheffler's group in Houston, in collaboration with Castle Biosciences, reviewed all of their patients who had a BAP1 mutation in the tumor, so only in the tumor. And it looked like about a quarter of those patients actually had germline BAP1, which is a number much higher than we initially thought. So to Dr. Borja's point, perhaps a little bit more broad screening in appropriate situations can be helpful. And so our next talk is about systemic surveillance and early detection of metastasis. So this is something that I know a lot of people are very interested in. And we have Dr. Leo Hernandez-Aya to talk about this.
Okay, great. Thank you. Thank you all for being here. Thank you to the MRF for the invitation and for organizing this great event. So I'm going to talk about systemic surveillance and early detection of metastasis in uveal melanoma. I'm a medical oncologist here at Sylvester, and these are my disclosures. So by the end of the talk, I want you to understand a little bit more the importance of surveillance after we treat the primary uveal melanoma. And I'm going to try to explain how we identify those patients that are at higher risk, how we can personalize the follow-up of those patients, and really talk a little bit about the importance of that early detection to be able to enroll patients in clinical trials and plan treatment. So you've seen this slide probably several times with this diagram about uveal melanoma. And I just wanted to highlight that it's still rare, but it's a very aggressive type of cancer. We only see about 2,000 to 2,500 new cases a year in the US compared to, for example, breast cancer that we see more than 300,000 cases. So we don't have a lot of guidance in terms of what to do in some specific cases in terms of surveillance. So, but we know that about 50% of patients that develop uveal melanoma will eventually show metastatic disease. And if that happens, then the survival is limited, although it's been improving. And why we do surveillance after the eye tumor is treated. So basically because this cancer is aggressive and microscopic cells can sometimes spread before the eye tumor is diagnosed or treated. And this happens because, as you can see in this diagram, the tumor microenvironment or the uveal melanoma cells have this other components in the tumor, including blood vessels and other cells like fibroblasts and collagen. But particularly the blood vessels are important because these cancer cells can actually invade into those blood vessels and they can travel to other parts of the body even before we diagnose the tumor. So if one of these melanoma cells gets into the bloodstream, then that cell can circulate in the body, and sometimes years later, it can show up in a distant organ. So, and we know that the most common site of metastases of uveal melanoma is the liver. And this is a schematic representation of what happens. We have a primary tumor in the eye, but if those circulating melanoma cells reach into the bloodstream, they can find a home in the liver. And sometimes they arrive there as single cells and they start to develop an environment that is, or they find an environment that is helpful to them, and then they start developing a tumor. So when we find these cancers early, we can potentially delay this progression, or if we can enroll a patient in a clinical trial, potentially decrease the risk of that happen. But not only in the liver, we can see metastases, we can also see metastases in the lung, in the skin, lymph nodes, and other organs. So if we wait until we develop symptoms associated with metastases, then it can be too late. So patients frequently ask me about what symptoms can I experience if there is a metastasis in my liver. And these are the commonly reported symptoms, but those are usually found when the cancer is too large or is already starting to block structures. And the goal of these surveillance programs are to try to identify the cancer before it starts to cause symptoms. Because as I said, many patients with early metastases have no symptoms. So how we try to identify which patient has a higher risk. And we know over the years that there are multiple factors that are involved in this, in the risk of recurrence of melanoma. So we have tumor genetics, we have a new factor, a new expression, a gene called PRAME, chromosome changes, BAP1 loss, tumor size, the location of the tumor. So all these are important factors to take into account. But more recently, we have a great tool that is called the gene expression profiling that we've been using in the clinic to try to identify those patients that are at higher risk. And I like to think about the process of melanoma evolution, thinking about these clusters of mutations that sometimes we can find. So for example, when there is this is a normal melanocyte, so we frequently don't find this, but they can develop one of these initiating mutations in one of these genes that are in the GQ pathway. And then if one of those mutations develop, then those cells can start to proliferate, but they're not malignant at that point. It's not until they develop one of these three other mutations, BAP1, SF3B1, or AFAX, where they can transform, when that benign tumor transform into a malignant melanoma. And now, after extensive research, we know that those mutations can guide us to try to understand who will develop metastases. So, for example, if we have IFX or SF3B1 mutations, those patients tend to have a lower risk of metastases or have a longer latency in terms of the development of metastases. But if we find a BAP1 mutation, then that confers a higher risk. And I was talking a little bit about this gene expression profile test that we've been using in the clinic. And what it is that your ocular oncologist, when at the time of treatment of the primary tumor, can get a biopsy from the tumor, and we can send that a biopsy to Castle Bioscience, and they will do an extensive analysis of the tumor, so they can tell us what the class is based on a gene expression profile study. So, for example, we can detect class 1 tumors or class 2, and they can guide us in terms of the risk of recurrence. So, for example, here you can see that those tumors that are class 1 have a very low risk of recurrence, and most patients that are class 1 are free of metastases, up to even 5 years of follow-up. But those that have a class 2 gene expression have a higher risk of recurrence. And this came after a lot of work done by the cooperative oncology group, that ocular oncology group that was led by Dr. Harber. And more recently, we are doing an additional test called PRAME, and this basically increases the detail in terms of what the prognosis is for the patient. So if we add a PRAME expression to a patient with class 1, we can detect those patients with class 1 that can metastasize or have a higher risk of recurrence, and the same for class 2. So basically, this PRAME expression is associated with a poor prognosis and higher metastatic risk. So we can really identify those patients that are gonna progress. And when we incorporate a PRAME into this model, basically it's giving us additional information to refine this prognostic tool. So if we have the same mutations that led us to find that or develop the malignant melanoma, and those tumors also express PRAME, then the risk of metastases is higher. So with all this information, we can actually talk to our patients and discuss, okay, now we have the primary tumor treated, you're recovering, and we have this test that was done on the biopsy that was performed, and we can identify one of these risk categories: low risk, intermediate risk, and high risk. And based on those factors, we can plan or organize or recommend a program to surveil, to do different scans, to try to find the metastases earlier than in other situations. So, for example, low-risk patients, we will call them class 1, PRAME negative, because the risk of recurrence is only 5%. So MFS is metastasis-free survival. So 95% of patients with class 1 PRAME negative are free of metastases. So we don't really do a lot of scans in those patients. We sometimes, we can see them once a year, check on them, but normally we don't do a lot of scans because the risk is low. When we go into the intermediate risk, for example, a class 1 PRAME positive patient, the risk of recurrence is about 20%. So 80% of patients are going to be free of disease. So now we're going into a more intermediate risk. So we see those patients more frequently, for example, every 6 months. And we do scans also more frequently to try to detect the disease. And then for those high-risk patients with class 2, PRAME positive or negative, and you can see the risk of recurrence there, then we do a high-intensity program of surveillance so we can detect the cancer if it's gonna come back. So the imaging tests that are commonly used when we do this surveillance, we highly recommend doing MRI of the abdomen. As I said, the liver is the most frequent organ that develops metastases. So the best test to evaluate the liver is the MRI, and we do it with contrast. We can also do CT abdomen with contrast in specific situations where an MRI is contraindicated, and we also include the chest in our follow-up because, as I said, there is a possibility for metastases to develop in the lung. So with all this information, and this is relatively new, we are trying to develop more comprehensive guidelines to guide oncologists and treating physicians into how to do the surveillance for these patients. And there is no really standardized guidelines at this point. So we did this with the leadership of CUG. We did this Delphi online survey that basically included medical oncologists, ocular oncologists, radiologists, and surgical oncologists from North America and Canada. And we try to do this method to get consensus on recommendations in terms of surveillance. And we try to, come up with recommendations and what the panel recommend for patients with intermediate risk is to do scans every 3 to 6 months for 5 years, and then annually for at least 10 years. And as I said, we normally recommend MRIs as part of the screening is preferred over CT scan or ultrasound. And then for those patients with high risk, we do this follow-up more frequently with scans every 3 to 6 months for the first 5 years, and then every 6 to 12 months for at least 10 years. Sometimes we do follow-up for more than 10 years because we have seen recurrences of uveal melanoma after 10 years. We normally don't recommend PET scans, and I know for cutaneous melanomas, we use PET scans frequently, but for uveal melanoma, is not very helpful in our follow-up. And this is an example of why we use MRIs. And you can see here on the left, this is a CT scan, and the liver is, I don't know if you can see my pointer, but on the left is the picture of a CT scan, and on the right is the MRI. So on the left, this CT scan did not show any evidence of metastases, and we couldn't see, any abnormalities in the liver. But in the same patient doing an MRI the same day with contrast, you can see little dots there that are actually small tumors. So that's why MRIs are recommended. And then in the bottom picture is a PET scan on the left that also does not show really any abnormalities. But when we do an MRI, we can see that there are small tumors. So clearly, MRI is a better tool for surveillance. And when we have that diagnosis, or when we are doing these scans, we want to try to understand why the tumors are coming back, but also when they come back, why we're doing this imaging. So, and the idea is that there are numerous or increasing number of treatments for uveal melanoma, and you're going to have a full lecture about treatment of uveal melanoma. But I just wanted to highlight that with this number of treatment options, it's important to do a surveillance early so we can identify if a patient is a candidate for one of those therapies. And for example, during the surveillance, we do different testing, including the HLA test. And this HLA test is very important because, as you're going to hear, that one of the drugs that we're now using for metastatic melanoma is called tebentafusp. And that medication is only effective, or can be potentially effective, in patients with this HLA type. And then with the scans, we can also find patients that have liver only or liver dominant disease. We can evaluate the performance status and do other testing during that surveillance period. And this is a busy slide, but this is just to highlight that there are numerous treatment options that are being investigated, and we can use now biomarkers to kind of guide us on what treatment could be potentially better. And there is a lot of research going on to try to investigate what is the best therapy for a specific patient. And if I have a few more minutes, I just wanted to highlight that tebentafusp is the FDA-approved therapy for HLA-A2 positive patients. And this trial had a specific analysis, and it showed that patients that had smaller tumors actually did better with this drug. So if we are doing surveillance and we are trying to identify those patients early, then those patients can benefit from this kind of treatments that you're gonna hear about. The same for the melphalan percutaneous PHP treatment, the Hepzato kit, that it's high dose of chemotherapy into the liver. So this treatment is also approved for patients with less than 50% of the liver involved by metastases. So again, finding the metastases early will allow that patient to potentially qualify to this kind of treatments. And in terms of, for example, clinical trials, we have this trial here at Sylvester, and this is investigating an intratumoral oncolytic virus. And when we are evaluating a patient for a clinical trial, we have to go through different inclusion and exclusion criteria. For example, for this clinical trial, we have one of the inclusion criteria is having low LDH and low burden of disease in the liver. So again, if we wait until symptoms develop, it might be too late, and the patients may not be eligible to participate in this kind of trials. So I want to finish here because you're going to hear about all these cool new treatments from Dr. Khushalani. So the key take-home messages are that uveal melanoma can metastasize after the eye tumor is treated. And that, again, we can use all these new tools that can help us identify which patients have a high risk and of recurrence. And if we detect the metastases early, then the patient can be eligible for better treatments and potentially can have better outcomes. That's thank you.
You mentioned the increased frequency of scans for those at high risk. Once somebody's realized that risk and has metastasis, how does the scan frequency and type change? Perhaps do you go to other sites? Do you add increased frequency, et cetera, et cetera?
Yes. So when you're saying when we find metastases, then how it changes? Yeah. So if we find a metastasis, then usually we will do a biopsy to confirm if it is actually, a metastasis, and then we will, plan a treatment. And usually during the treatment, then the frequency of scans become, is different, or we include other sites. Sometimes then if we're suspecting that maybe the cancer has spread to other organs, then we start doing maybe additional tests to find that out. Yeah.
Quick question. I'm forgetting the research on this, but isn't there a group of people, I forget which predispositions or genetic predispositions, where the increase in risk of metastases happens at year 7? Isn't there a second bump down the line? I just wanted to get clarity on that.
Yes. So one of the slides had the 3 different pathways of the evolution. And the one at the bottom was the BAP1. Usually those patients tend to metastasize early, sometimes within 2 years of diagnosis. But then those patients that have those other mutations, those are the ones that sometimes we see metastasizing after year 5, year 7, 10, or even beyond that. So that's why the class and those genes are included in the gene expression panel that we do with Castle to try to identify that risk.
And sorry, just one follow-up. So for those folks, then, do you ever change the surveillance schedule? So for later on, maybe you actually increase the surveillance monitoring, or no?
So it's not that we change the frequency, but we can continue doing the scans. Yeah, because we also don't want to expose, a lot of patients to the radiation from the scans, and, sometimes, false positive findings. So we want to try to use this test to guide us on how frequently, but we can continue doing scans in those patients. Yeah.
Okay. 2 unrelated questions. The first is in surveillance of patients without genetic information. Where do they fall in your algorithm? Are they
without?
Yeah,
you're saying, yeah.
Decline Castle, or
yes.
Castle's non?
Yes, exactly. So I included, we can use clinical factors as well. The tumor diameter is important. The location of the primary melanoma is important. So there are some clinical features that we can use to identify a higher risk if the biopsy was not done.
Okay.
There are also other chromosomal, studies, but those also need a biopsy. So really, if the biopsy was not done, then we have to use more the clinical features that help us with the classification.
Okay. Second question is related to targeting of PRAME mutation patients. It seems like that's low-hanging fruit for a drug antibody or radioisotope antibody conjugate. Do you have studies open like that? Are there things in the pipeline?
In the pipeline. So we actually have a trial that is currently open with cell therapy. So these are engineered T cells that can identify and target PRAME that is expressed in uveal melanoma. So we know that PRAME is expressed in a lot of cancers, but melanomas and uveal express PRAME in large quantities. So we have and you're going to hear a little bit about it. But it's open, and we're seeing very encouraging results in that study.
So I had enucleation in June of 2024, and I was told it was a class 2 tumor, but I was never told about a PRAME rating. So would it have been done then, or is it still possible to go back and get it? And then the second question is, I get scans every 3 months. Why would it be every 2 months, or why isn't it every 6 months?
Yeah.
Where was this 3-month number? Where's that come from?
Yes, those are very good questions. So the expression of PRAME and the addition to the class stratification was recent. We've been doing it now for a couple of years more routinely, but so I think that's why it was probably not done in that initial gene expression profiling. But the fact that it's a class 2, just by knowing that information, we would recommend high intensity surveillance. And the 3 months, it's in the oncology world, it's a good interval to find changes, because you don't want to also be doing scans very frequently where you don't see significant changes. And you can have also false positives that lead to anxiety or procedures. And so we think that 3 months it's a good interval. And then as time goes on, maybe after 3 to 5 years, we actually start spacing out that interval.
So Ed, I want to say really quickly that if your original sample was done within the last 2 years, they may have residual tissue at Castle. So first, I would talk to your treating physician and see if they have that information. Second, if they don't have that information, they may be able to get in contact with Castle and they can rerun the analysis with residual tissue if possible. And then third, they can sometimes send additional slides from the enucleation. The results tend to be more accurate if done within the last 5 years. So you may still be able to get that information. Okay, one last question.
I'm sure there's probably no research on this, but I'm just wondering if there's any known correlation between pregnancy and higher risk for metastasis.
Yeah, so in cutaneous melanoma, we have some more data. So in uveal melanoma, I'm not aware that we have solid data to support that. Yeah, I don't know.
All right, thanks so much.
Thank you.
All right, so now we're going to be talking about adjuvant trials for high-risk uveal melanoma patients with Dr. Jose Lutsky.
Do I control it then? Okay. Hi, good afternoon. Thank you again for inviting me to speak here. Great to see a lot of people in the audience. I think is this being attended by online as well?
It's being recorded for later
Okay.
distribution.
So I'm going to talk about adjuvant therapy. So this is something that just maybe 5 years ago we wouldn't even be talking about. There wasn't enough interest, and there wasn't really a good way to determine who were the patients that would be appropriate for that. And actually, thanks to all the patient-centered groups and patient-centered involvement, there's been a resurgence of interest in treatment of uveal melanoma, and we've seen really an explosion over the last few years. So these are my disclosures, and what we want here is to find out among this universe of people with uveal melanoma, to pick that person that will develop recurrent disease. And, there are various methods of trying to figure out who that person is. AJCC, which is the standard staging, is one way of doing that. The advantage is it doesn't require a biopsy, can be easily done, but it's not as precise as we would like. We could also combine clinical features with cytogenetics. It does require a biopsy of the primary tumor. We can do DNA sequencing, and there is a whole classification of uveal melanomas based on that, and that can also give you some information in terms of prognosis. But the only test really that has been prospectively evaluated by the Collaborative Ocular Oncology Group is this gene expression profile that gives you a class 1, class 1A, class 1B, and class 2 discrimination in terms of risk for melanoma. It does require biopsy of the primary tumor, and that's usually done by ocular oncologists at the time of plaquing, doing the brachytherapy. So Dr. Hernandez already showed this. This is more recent data from the second iteration of the Collaborative Ocular Oncology Group called COOP2. And this is 1,600 patients. It's a rare disease, as you all know. So 1,600 patients is respectful. And this was done prospectively. And on top, you see the blue line is a class 1 versus class 2 in red, and we're looking at survival curves. Obviously, the lower the curve, the worse the survival. And the second in the middle, the graph in the middle, we're looking at PRAME, and you can see here what the impact of PRAME is, PRAME positive versus PRAME negative. And the bottom line is really, if you use all of those factors together, class 1 PRAME negative, class 1 PRAME positive, class 2 PRAME negative, and class 2 PRAME positive. And you can see that as you add those, there is a progressive decrease in melanoma-free survival. So having that data being prospectively collected is very, very helpful and allows us to design trials for the highest risk groups. So not to say that it hasn't been attempted before. There's a number of trials that have been done in patients with uveal melanoma with different forms of adjuvant therapy. I'm not even going to go through all of those because they're all negative, but it has been tried extensively. And these are some of the current trials, and this is sort of the landscape. The ones in red are trials that are active, but no longer accruing. The dendritic cell, a trial from Sweden, I believe has had trouble accruing. We haven't heard much from that. Dr. Sato's trial from Thomas Jefferson was recently reported, but it was not really randomized. And we're going to be talking about some of these other trials in the middle, the EP-NIVO trial for patients with high-risk melanoma. We're going to talk about neoadjuvant darovasertib. We're going to talk about tebentafusp. There is a trial also in Sweden with melatonin looking for 100 patients. And again, they're having a lot of trouble accruing. It's been open for several years. And the ongoing larger neoadjuvant darovasertib trial, we're going to talk about the trial that we're doing here, the Cresinostat trial. And there are 3 trials that are not yet active, but will be soon. And we're just going to touch upon those. So darovasertib is the new targeted therapy in uveal melanoma. And on the left, you can see in red, or just below that, that's where the GNAC and GNA11 mutations are. And those are the most common initiating mutations in uveal melanoma. And those mutations stimulate the proliferative pathway of uveal melanoma cells. And you can see just a little bit downstream of that, there is the protein kinase C gene, and that's what this drug darovasertib inhibits. And there have been other PKC inhibitors that didn't really work so well, but this particular drug has been effective. And you can see here, this is metastatic melanoma, and this is what we call a waterfall plot. And all these bars going down mean that there is a decrease in the size of the tumor. So the bigger the bar going down from the midline is the magnitude of a change in the size of the tumor. So this is sort of unheard of in metastatic uveal melanoma before, and 90% of patients had some kind of shrinkage receiving this drug, in this case in combination with another drug called crizotinib, and this is in a metastatic setting. But because of these results, early results, somebody in Australia decided to look at ocular melanoma before they got definitive treatment with brachytherapy, or even in patients that were about to get enucleation. So on the left, you see the enucleation cohorts. So there were only 6 patients, but you can see all 6 of those had some decrease in the size of the tumor before they got their enucleation. And the last patient on the right there had so much of a decrease that did not require enucleation. And on the right, those are the other ocular tumors, an additional 3 patients that did have significant shrinkage of the tumor. So based on that, there was a phase 2 trial, randomized, not really randomizing, assigning patients to 2 groups. So one group were patients that were going to have enucleation, and the idea there was to try to prevent enucleation. And the other group of patients were patients that were going to have brachytherapy or plaque brachytherapy, but the field of radiation was so wide that it would cause significant vision loss. So the objective there was try to decrease the amount of radiation that these patients would need. And this trial has been completed. It has shown some positive results, and that led to this other trial, now a phase 3 randomized trial, in which these patients with primary uveal melanoma will be treated again in 2 cohorts, similar to before, requiring either brachytherapy or enucleation. So this trial has started just recently, and patients here will be followed for 3 years. Now, moving on to tebentafusp, and I'm glad that Dr. Hernandez has already introduced tebentafusp. I'm sure you all know about tebentafusp because it's the only drug that is specifically approved to treat metastatic uveal melanoma. And tebentafusp is really a construct, is a T-cell engager. So on the left, you see what the drug actually is. There is one end, the top end, that binds very firmly to the target that we're, in this case, is GP100. GP100 is a peptide that's expressed in almost all uveal melanomas. So this end of the molecule binds very tightly to the target, and the other end actually is like floating around, and any T cell that has a CD3 receptor will attach to it. So it will allow cells that have not been sensitized to the tumor to actually attach to the tumor and kill the tumor. So, this platform now has been used to target different antigens, including PRAME, as was mentioned before. So this is the results of the trial in metastatic melanoma. The response rate does not appear very impressive, but it clearly showed an improvement in survival. And at 3 years, that was 27% for tebentafusp versus 16%, or 18%, I'm sorry. So this has generated this large study, the intergroup study, that it is going to be adjuvant tebentafusp compared to observation in patients that are HLA-A201 positive. As you know, tebentafusp would only work in HLA-A201 patients because GP100, in order to be expressed, requires this HLA, specific HLA molecule to be presented to the surface of the cell. So patients will have had definitive treatment for the primary tumor and then will be randomized. So this is a global study. It's going to be 11 centers in Europe where it's already open. And as of now, 5 centers in the US, maybe more. They may expand the number of centers in the US. So the primary endpoint is relapse-free survival, which is a time defined as a time between the randomization and a local distant recurrence or death. And the secondary endpoints is overall survival and safety. So I'm just going to just a few inclusion criteria because they vary a little bit depending on the trial. So here, the patients can go into this trial within the first 3 months, not after 3 months. So the maximum time is actually 12 weeks. And the criteria for patients to go into trial, there will be clinical criteria that will be related to the TNM staging that I mentioned before, HACC, or some genetic criteria. One of them is cytogenetics with monosomy 3, or the GEP that I mentioned before, GEP class 2. So here they do not require specific size of the tumor or what we call the largest basal diameter in this particular trial. And then everything else is pretty sort of standard for trials I'm not going to get into. So this is sort of the schema. Patients will have either their surgery, enucleation, or radiation therapy, and they will be tested for HLA-A201. That needs to be positive for them to be on the trial. And this all has to occur within 3 months. And then patients will be at random assigned to receive tebentafusp or observation. And they will be at 12 weeks, 24 weeks, the treatment stops. So it's a treatment for 6 months. And then the patients are followed to look at the rates of recurrence. So there will be a total of 29 patients. So it'll be evenly divided between the 2 groups. So this is very close to opening in the US. So this is another trial. This is a smaller trial than looking only for 19 patients at Thomas Jefferson, Dr. Cedar. And this is a neoadjuvant trial for patients to receive tebentafusp. And here they're looking for locally advanced primary uveal melanoma, again, HLA-A201 positive, and they will be treated with tebentafusp weekly for 8 weeks. This is before the primary treatment. Then they'll have the primary treatment, either the plaque or enucleation, and then they will be followed. And the primary endpoint is to look at regression before they have the primary treatment in 20% of patients. Again, this is a Simon stage 2 design. It's really a signal-seeking trial. And these are the inclusion-exclusion criteria. So I want to talk about our Presenastat trial here, but I need to take you back to the BAP1 again. So I'm so glad that BAP1 was talked over and over again. So we don't need that much introduction to it, but it stands for BRCA1 associated protein. That's what BAP1 stands for. And it's the most common mutation that you see in patients who have GEP class 2. So this work has been done by Dr. Harbour in his lab, and essentially it has to do with the function of BAP1. When BAP1 is mutated, it loses its function. And what does BAP1 do? Does a lot of stuff. But I want to focus on this particular function of BAP1, which allows the undifferentiated melanoblasts to differentiate into melanocytes. And when cells differentiate, they die. When they don't differentiate, they continue to grow. So we think this is important in the genesis of uveal melanoma. And what was shown by Dr. Harbour's lab is that when BAP1 is active, it suppresses an enzyme called HDAC, or histone deacetylase, a particular type, class 4. When BAP1 is gone, this histone deacetylase is now active. So through a lot of screening for drugs that could suppress this histone deacetylase, in the lab, a drug called quizinostat was found, which is towards the end here of the screening. So over 5,000 compounds were screened. And this led to this adjuvant trial that actually, this is out of order. I need to go to this one first. So this is showing that in this mouse fat pad model, the human uveal cells that are BAP1 mutated, there are the two on the left, are suppressed by quizinostat. And you can see in the bottom where the arrows are, the lower tumors are the tumors that are controlled. And on top of that are the tumors that were treated with quizinostat. You can see that it inhibited the growth of those tumors. Whereas if you look at the lines that were not BAP1 mutated, it didn't seem to have as much effect. So this led us to pursue this trial, which is giving quizinostat for patients with high-risk melanoma. We are the coordinating center. There will be a number of other centers in the country that will be participating as well. We're looking for 60 patients. And our inclusion criteria, in addition to class 2 GEP, patients should have a largest basal diameter. So the size of the tumor should be 12 millimeters or greater. And why are we doing that? Because beyond PRAME and class, the only other factor that has an influence in prognosis is the size of the tumor. Not as great as class, but it does have an influence. And when we designed this trial, PRAME, we didn't know that much about PRAME. That's why we did not include PRAME on this trial. But if you have a melanoma that's 12 millimeters or greater, and it's class 2, at 36 months, at 3 years, the chance of the tumor coming back is about 40%. So what we want to do with this design is to decrease that chance by minus 15%. We want to go from 40% to 15%. So this is the primary endpoint, or conversely, increase the disease-free survival from 60 to 75%. So the secondary endpoints, progression-free survival, overall survival. We're also looking at ctDNA, see what's happening if we can detect tumor DNA in these patients and what happens over time, what happens to treatment, during treatment. And we also want to look at histone acetylation, which is the enzyme that we're trying to inhibit to see if we're hitting the target in the tumor. So we do have some preliminary data. We have consented 22 patients in our center. We're about to get the other centers involved. And what you see on the upper right, is results of ctDNA. And you want to look at the red line. And the red line is we're looking at the mutated uveal melanoma cells that have that particular GNA mutation. And you see that in the beginning, it was detectable, and then it became undetectable. So this patient had been treated 5 months earlier. So we think that we're detecting still additional, some cells are still dying in the primary tumor and they're releasing the DNA, or maybe it's the result of the treatment, we don't know. Or this is just a natural decay in the cells. Second patient was 4 months after brachytherapy, and the third patient was also 4 months. So you see, we were able to detect in these 3 patients. And the bottom one, the green bars are one patient, and the blue bars are another patient. And here we show that we show a decrease in the activity of the histone deacetylase in the white cells of these patients. So we show that we can detect ctDNA. We show that we are hitting the target. So the trial is continuing. We had to stop the trial because there was a serious adverse event with one of the patients. So we decided to put it on hold until we investigated it further. But we're ready to reopen. Now, this is another trial. This is the adjuvant ipi/nivo trial. This is the phase 2 trial with a synthetic control, meaning not a true randomization. And this was done by, again, a group of institutions. And essentially, they were looking for uveal melanoma, high risk. And in this case, they did look for a largest basal diameter of 12 millimeters or greater in GP class 2, but accepted other definitions of high risk as listed there, including monosomy 3 and some other parameters like this LUMPO calculator that uses clinical data and cytogenetic data. So this is the result that this was suggestive of activity. The patients that were treated with ipi/nivo at 3 years, 70% were disease, distant metastasis free, and 43.4% of the control patients were not when compared to this other group of patients. So this has led to, here's to show that this was toxic. We know that ipi/nivo was toxic. One patient on the trial died, and about 48% had significant toxicity. But this went ahead to ECOG is working on doing this as a randomized trial now. So it will be 252 patients, and they're looking for a 45% reduction in the risk of metastasis. And patients will be randomized 2-to-1. So 2 out of 3 patients will go to the treatment arm, and 1 patient will go to observation. So patients will be treated for 48 weeks and then followed. So this has not started yet. It may take a while because it's a cooperative group, and those take a little longer to get activated. I'm going to skip this. And so the percutaneous hepatic perfusion was discussed here before. It's a treatment that is now approved for melanoma that is involving the liver. And there is some talk about doing an adjuvant trial for patients with hepatic perfusion. Obviously, the idea is to treat the cells that are undetectable at the time of diagnosis and maybe prevent a recurrence in the liver. The treatment's probably not going to do anything to prevent extrahepatic disease, but as we know, hepatic recurrence is the main issue with this disease. So this is one potential design, and the endpoints will be distant metastasis-free survival and the time to metastasis. So patients will have definitive primary treatment within 6 months, or that is variable, and then they'll get a couple of treatments with this Hepzato or PHP, and then will be followed. And here is the darovasertib and crizotinib combination for metastatic disease. As of last week, that we already have results of this trial in metastatic disease, and it is a positive trial. It showed that the patients that were treated with the combination did a lot better in terms of distant metastasis-free survival. We still don't know whether there is an impact on survival, but it's likely, but we don't have that data yet. But I'm showing this here because I'm sure there will be adjuvant trials with this combination now that this is very likely to be approved. So that's all I had. I'm happy to answer any questions.
But I love these reviews. This is great, from ophthalmology to have the medical oncologists, this collaboration is wonderful. And I think that the Ipi-Nivo trial was interesting. I had a question, like for the patient that passed away, are there any things you could try to use to predict who might not do as well?
Yeah, I mean, we know that Ipi-Nivo, the patients, eventually a small number of patients will have a serious immune-related adverse event from Ipi-Nivo and they can die. And myocarditis is something that has a 50% fatality rate. There are a number of publications now trying to define predictors of toxicity, but then they have not yet been validated. They need validation, and that will be tremendously helpful to screen for the appropriate patients to treat with immunotherapy. We did a trial in combination of nivolumab and relatlimab here with 27 patients, and in our correlatives, we actually found a population of patients in the T cells, a specific subset of T cells that predicted for higher toxicity. So we're working on a manuscript on that, but still will need to be validated prospectively.
I've seen some information floating around lately about NBM BMX trial that's going on, a dosing study that they're doing, but I hadn't yet heard what gave that promise to step into that in the first place, what effect it's supposed to have.
I'm sorry, which trial?
It's 3 letters followed by 3 letters. It's November Bravo Mike NBM BMX Bravo Mike X-ray.
No,
Okay.
I cannot comment on that. Anyone? Yeah.
What are the treatment options for patients HLA negative? The patients that cannot be treated with tabentafusp, I guess they are HLA negative patients.
I'm sorry, I have a hard.
HLA-A*02:01 negative.
Yes.
Patients, she's asking what are the treatment options if they can't get it?
Yeah. So, the trial, this trial that I just mentioned, the combination trial, was specifically for HLA-A*02:01 negative patients because at the time that the trial was conceived, tebentafusp was approved and it was a first-line trial. So they could not put those patients in a first-line trial or something else. So once this drug is approved, and I'm sure there will be a compassionate use program from the company to treat those patients. But beyond that, there are, for example, the RP2 trial that Dr. Hernandez mentioned would be appropriate for HLA-A*02:01 negative trials. Immunotherapy is an option. If the disease is mostly liver located, then there are a number of liver-directed therapies that can be used for that.
I'm curious, mostly for selfish reasons for my patients, but when you say local therapy with radiation, is that inclusive of things like proton therapy, or is it only brachytherapy?
I think it's a primary definitive treatment. So it could be that, it could be proton beam, for example. It doesn't have to be,
Okay.
Excellent. Well, let's take a 10-minute break. So we will have everyone come back at 3 o'clock, and we will try to start at 3. Thank you, everyone. Yes. So we are going to get started with our next portion of the programming. Yet again, I have failed to keep us on time. But again, great discussion. Before we get into the next session, I also want to let people know that there is an alternative session going on in the Arkin boardroom down the hallway. And there's space for open discussion with the social workers. So if you don't want to hear about the metastatic disease component of things, you're welcome to head down the hall. And now we will talk about both systemic and local therapy for metastatic uveal melanoma. And our first speaker is Dr. Matthew Perez.
Thank you, everybody. And so I'm Matt Perez. I'm a surgical oncologist at Moffitt Cancer Center down in Tampa, Florida. I'm specifically in the division of cutaneous oncology. And so in the melanoma world, that's where my ties are with the uveal melanoma. And I'm one of the 2 surgical oncologists that actually perform percutaneous hepatic perfusion at Moffitt. We have a quite large multidisciplinary team that takes care of these patients, whether it's medical oncologists, pharmacists, surgical oncologists, radiation oncologists, and then of course our interventional radiologists. So it's quite a big team there. So today what I will talk to you all about is for metastatic uveal melanoma will be the regional therapy options. So the kind of the local and regional therapies specifically for liver predominant or isolated liver disease. I did want to say thank you to the Melanoma Research Foundation for the opportunity to present and to the Planning Research Committee. I think I always take a lot of, or I always cherish these opportunities to talk to patients. I think we go around and give these talks a lot to colleagues. We talk about p-values and all sorts of things, but at the end of the day, this all is about the patients, and it's all about improving our care for our patients. And so whether it's a discussion about skin cancers at a local YMCA or something more formal podium talk with the Melanoma Research Foundation, I think these are awesome opportunities for us as physicians to really connect with our patients and talk about the things that we're doing. So we've had a lot of presentations today about uveal melanoma, and so I'm not going to go into too much about uveal melanoma, but as it pertains to local regional therapies for metastatic uveal melanoma, we know this is a rare disease. About 50% of these patients will develop metastases at some point. And interestingly and very specifically for uveal melanoma, over 90% of these patients will develop either isolated or predominantly liver metastases. I think one of the key things to talk about with metastatic uveal melanoma is that this is often a miliary disease in the liver, and although there may on radiology look like it's confined to one lesion, it's often a little bit more miliary, and so that knowing that kind of helps us determine how we treat these patients. The treatment options for metastatic uveal melanoma, systemic therapies, which Dr. Kushalani, one of my colleagues at Moffitt, will talk about after this and go into more detail. And then there's these liver-directed therapies, which kind of focus more on treating the liver disease primarily. And as we know through some of the talks already today, and with this one as well, there's 2 FDA-approved treatments for metastatic uveal melanoma. So tebentafusp, which was already discussed and will be discussed a little further, a systemic therapy, and then percutaneous hepatic perfusion, or HEPZATO, which is a regional therapy for liver predominant metastases of metastatic uveal melanoma. I do want to give credit to one of my colleagues, Dr. Jonathan Zager, who was the PI of the FOCUS trial, which ultimately led to FDA approval of percutaneous hepatic perfusion in the United States. He's been one of my mentors for a long time, one of my colleagues now, and certainly played a big role in this, and which has allowed us to bring this into the forefront at the United States for the treatment of these patients. So local and liver-directed therapies for metastatic uveal melanoma. There's certainly surgical resection is an option. Going back to my first slide about sometimes that the disease is a little bit more miliary than it looks like on the imaging. Surgical resection is typically reserved for select patients that have had these long disease-free intervals. Kind of had withstood the test of time of developing more disease, and we don't typically. This is not in our routine practice. Where we work, but certainly is an option in some patients. SBRT, or stereotactic body radiation therapy, is a definitive radiation therapy. to lesions. That's also an option and can be done in select patients, similar to surgery. As far as the patient selection, we don't necessarily have any strong randomized trials looking at these modalities, but they certainly are options. Thermal ablation techniques, so microwave ablation, and other ablation techniques. This is also, again, similar to SBRT or surgery, where it's a local therapy specifically targeting, kind of externally targeting a liver lesion, and certainly is an option. And then there's the transcatheter intra-arterial embolizations and infusions. These are a little bit more what we kind of consider as the liver-directed therapies. In the treatments in red are the ones I'll discuss today with everybody. So arterial chemoembolization, SIRT, or selective internal radiation therapy with beads such as Y90, percutaneous hepatic perfusion. There's also hepatic artery infusion pumps, and then immunoembolization techniques as well. So a lot of techniques in this space, and certainly a lot of opportunity for us to grow our knowledge and our technique with taking care of these patients. One of the things that regional therapies of the liver really capitalizes on is the relative dependency of liver metastases to be supplied by the hepatic artery. So in the liver, there's two inflows of blood flow. There's the hepatic artery and the portal vein, and the liver metastases typically rely on the hepatic artery. So this is a way of kind of accessing the inflow to these liver metastases and giving treatment to these liver metastases, but at the same time trying to spare as much normal liver parenchyma as possible. Selective internal radiation therapy, or Y90. So this is a delivery of microspheres. Delivery of microspheres that are labeled with yttrium-90, and it's done through the hepatic artery through a transcatheter approach. It gives high-dose radiation to lesions, and the goal is to really deliver high-dose radiation to these lesions, but minimize damage to the normal liver tissue. Talking with our radiology colleagues and as our experience, these are really preferred. This technique's really preferred for focal lesions with really a distinct kind of blood supply and a distinct compartment of involved disease, where they can really target the disease, but also really limit how much of this is given in the normal liver parenchyma to reduce any chances of radioembolization, liver failure, and things like that, or liver disease in the normal parenchyma. There was a prospective in 2019, a prospective phase 2 trial looking at patients that were treatment naive, both treatment naive and patients that had progressed on prior immunoembolization. The median progression-free survival in these patients was 8.1 months and 5.2 months respectively. However, greater than 90% of these patients did ultimately develop new hepatic and extrahepatic disease. And as you can see, the median overall survival rates were pretty close to 20, a little under 20 months. Since then, there's been systematic review of 6 studies, which showed the median overall survival to kind of range anywhere from 9 to 24 months. And as with a lot of these liver-directed therapies with a rare cancer like metastatic uveal melanoma, a lot of these articles and papers that have been published have been kind of more short, smaller series, retrospective reviews, and things like that. And so there is a little bit of a wide range here as far as survival data. Transcatheter arterial chemoembolization. So this is an embolization of the metastases with delivery of local chemotherapeutic agents. It can be used, the vehicles that allow for this delivery of chemotherapy can either be lipiodal or drug-eluting beads. This is a therapy that's typically preferred for disease that's more confined to a lobe of the liver, a region of the liver. So the Y90 that I just mentioned was more of this is a focal, inflow of blood supply to one particular lesion. This is more with the lesion distribution being more for a lobar disease or bilobar, so meaning portions of the liver. And the overall survival also had a kind of a significant or a wide range here in the studies, 5 to 29 months. The largest prospective trial in 24 patients showed an overall response rate of about 20% with a median overall survival of 5 months. I think the important thing in these studies is that there's a lot of selection bias with them being retrospective, patients not candidates for this or candidates for this and previously. And so some of them being treatment naive, some of them being heavily treated. And so oftentimes the data that comes out of these trials can be very, particularly skewed towards the patient population more than the treatment. So percutaneous hepatic perfusion is something, is a regional therapy that I'll also talk about today. It's a unique procedure where we actually can isolate the blood supply to the liver, and it allows for high dose, actually it's really an infusion of chemotherapy through the hepatic artery that otherwise wouldn't be tolerated systemically. We give the agent melphalan, and we've got a very high dose of melphalan, but it only goes into the liver through the hepatic artery. It treats the metastases, and then when the drug is exiting the liver, it's captured with a balloon catheter, and actually the blood is returned through an extracorporeal catheter and cleared of the chemotherapy byproducts and toxins before the blood is returned to the body. And so it allows for high dose delivery of chemotherapy without the systemic, or at least the major systemic toxicity that you would get with giving this same medicine IV. Or intravenously. The inclusion criteria, there's quite a bit of inclusion criteria and patient selection in these patients. However, the kind of the main take homes from the inclusion criteria and who's candidates for these patients is you either want to have no or at least minimal extra hepatic disease or disease outside of the liver. You want to have less than 50% disease burden within the liver, and then a good performance status to undergo the procedure, which requires general anesthesia and some hemodynamic shifts during the procedure. And so we want to make sure that the patient has a pretty good functional ability going into the procedure. Here's some images kind of illustrating the procedure as I was talking about with the double balloon catheter. The melphalan is infused directly into the liver via the hepatic artery. And then there's an extracorporeal circuit, which allows for clearing of the chemotherapy prior to return. Here's some actual fluoroscopic images from procedures that we did. So on the left there, you can see the double balloon catheter. And there's, you can look at the cephalad balloon. There's a little bit of a kind of an acorn shape there. That's what we use to make sure that it's wedged right into the cavoatrial junction to allow for, proper isolation. And then we perform a venogram, which is where we inject contrast into the vein, the IVC, to make sure that ensure that we have complete isolation of the blood supply. And then the other picture is an arteriogram looking at catheterization or selective catheterization of the hepatic artery. This is critical in delivery of this. We want to make sure that we don't have any tributaries or any aberrant arterial vessels that would potentially lead to escape of the chemotherapy outside of the liver. And occasionally we need to do a small embolization of a small tributary of or aberrant anatomy so that does not happen. The FOCUS trial was the phase 3 trial, which led to the FDA approval of this for metastatic uveal melanoma. It was initially actually a randomized study looking at liver perfusion versus best alternative care. However, in the trial, we're actually losing some patients that were getting randomized to not get PHP, and they were going to Europe to get the study done, or the treatment PHP, which has been approved since 2012 there. And so we actually transitioned to a single arm PHP. So this is up to 6 PHP treatments. Every treatment is every 6 to 8 weeks, imaging every 3 months. And the primary endpoint was overall response rate. As you can see here in the 91 patients that received treatment, the overall response rate was 36.3%, with a little bit over 7% of patients having a complete response. The disease control rate was 73.6%. So a lot of patients had good disease control with a duration of response of about 14 months and survival, median overall survival of 20.5 months. The patients that were randomized versus best alternative care, the liver perfusion group, progression-free survival was 9.1 months versus 3.3. And there was also a subgroup analysis performed in this study looking at different subgroups. And really the summary of all that was that there was improved median overall survival in the lower median hepatic tumor burden, patients with less complete % liver involvement, and then patients with lower or normal serum lactate dehydrogenase levels. And so that's important as we talk about how we sequence these treatments and taking care of these patients. And when there are multiple options, which one do we prefer? At least first or afterwards, and things like that. Post FDA approval, we have performed quite a few of these procedures in our patients. As you can see here, the response rate's about 44%. Since that's been done, these are the standard of care patients, so patients outside of clinical trial. and the disease control rate being 83%. This is higher than what was reported in the clinical trial. We certainly don't know at this point exactly why that's the case, although I would say that one of the leading theories that I have and that I know our group has with why our results are better was in the clinical trial, they were able to be included in the clinical trial if at baseline they had minimal extrahepatic disease that could be treated between the first and the second PHP. But if they developed any extrahepatic disease or new extrahepatic disease during the clinical trial, they were disqualified. They had to be taken off the trial. Now, what we can do in the standard of care setting is if one or two small lesions develop in a patient extrahepatically during this treatment course, and they are responding in the liver, we can still treat them extrahepatically with a local therapy, either surgery or radiation to an isolated small lung metastasis or a subcutaneous lesion, but still keep them on the PHP track, which ultimately the liver disease is ultimately what controls the prognosis in a lot of these patients. And so we can keep them on the trial and keep giving them PHP. And so therefore, we do feel that helps with keeping them on treatment and having better results. The hepatic progression-free survival. So we've also looked at using it as first and second line therapy, PHP, and PHP has performed better in our retrospective reviews for as whether it's a first line therapy or a second line therapy, and then for both hepatic progression-free survival or overall progression-free survival. So future directions with PHP specifically, we've learned that upon exposure to the chemotherapy melphalan, that melanoma cells have actually shown to increase immune-related markers. And so, how can we capitalize on that with a synergistic effect by combining PHP with other systemic therapies to allow for not only the direct anti-tumoral effect, cell death, but also the activation of the immune system to potentiate, any systemic therapeutic agents. The Chopin trial out of the Netherlands was a recent trial that was published looking at the combination of percutaneous hepatic perfusion and combination immunotherapy, anti-CTLA-4 and anti-PD-1. And so what this trial looked at was either patients were randomized to either liver perfusion only or liver perfusion with combination immunotherapy at weeks 0, 3, 6, and 9. And the promising results came out of that, showing an overall response rate of about 76%. Disease control rate on close to 90% in the combination group. So at Moffitt, we actually just started an investigator-initiated trial where we're looking at actually PHP along with tebentafusp, which is another immunotherapy that acts a little differently than the others that we certainly Dr. Kushalani will talk a little bit more about. I know it's been already introduced to the group. And what we're planning on doing will be 2 liver perfusions for patients with the HLA-A*02:01 mutation, and then follow that up with tebentafusp for 1 year. And then depending on the biopsy done after systemic therapy, if there is any viable tumor, continuing the rest of the percutaneous hepatic perfusions, which will be 3 through 6. We will have good science being performed on the core. We'll do core biopsies both at the baseline as well as after the second PHP as well to kind of be kind of further characterizing these changes in the tumor. So that's an exciting trial that we have going. We've accrued 2 patients so far, and accrual started, and so we're looking forward to moving that along. So how do we manage patients at Moffitt, where we work with metastatic uveal melanoma? If there's isolated or predominant liver disease, we do favor early liver perfusion. And then for extrahepatic disease, if it's minimal, we can treat that with either surgery or radiation. But certainly if there's more of that, then that's where we move to a systemic therapy earlier. If HLA-A*02:01 positive, certainly we'll consider for this clinical trial. The advantage that we feel that liver perfusion has, percutaneous hepatic perfusion has with patients earlier is that we don't feel that you burn a whole lot of bridges by doing it. You've seen the data that shows that it works better with a little bit lower burden of disease. And if the patient progresses, they are still candidates for the systemic therapies. However, if they progress on the systemic therapies outside of the liver, then they are no longer a candidate for PHP. So we do feel that there's an advantage to earlier PHP. However, certainly we are understanding that we're still working on really getting good data to support kind of how to treatment sequence all of our patients and whether there's what roles there are in combining the systemic therapies with the liver-directed therapies. And with that, thank you for the time and for your attention. And I guess we'll go to Dr. Kushalani, and then I think we have some Q&A afterwards.
We'll have some questions.
Okay, perfect.
Thank you very much for the kind invitation, Dr. Williams and Curome and MRF team. It's certainly a privilege to be here. We did this meeting in Tampa a few years ago, so it's always nice to be a part of this group. And it's especially nice where we now have started seeing some new treatments. Have we cured uveal melanoma? Absolutely not. And there's a lot of work to be done. So we say this with a lot of humility. We're making progress, simple steps forward, but these are all steps in the right direction. These are my disclosures. These slides have been under my control, and I will discuss some non-FDA approved agents in this presentation as well. So some simple questions to sort of put this into perspective. What is the appropriate frontline option for therapy-naive metastatic uveal melanoma? How should we stratify patients? Is it just HLA-A stratification, so O2, O1 positive, which is about 41% of the US Caucasian population, a little bit higher in the European Caucasian population? Should we look at other options from a clinical standpoint? For example, burden of disease in the liver, kinetics, how quickly are these tumors growing? Serum LDH, which is a very strong prognostic factor in patients with advanced cutaneous melanoma, in fact, almost the single most important prognostic factor. Or even looking at timing from the time of treatment of the primary tumor to the development of metastases. So these are all questions that I don't think we still clearly understand, but clearly in terms of therapeutic options, with tebentafusp being the only systemically approved option for this disease, HLA-A stratification becomes exceedingly important. Does it matter if the patient has liver dominant versus extrahepatic disease? Dr. Perez eloquently defined a lot of that for us. So should a patient get liver-directed therapy first at the time of diagnosis of metastases? Should they get systemic therapy first and then defer liver-directed therapy to later? Or should we find a right treatment medium where we can incorporate both either concurrently or sequentially? In my mind, and some of the trials that I'll show you that were specifically for systemic disease, they actually excluded the patients who had received liver-directed therapy. It's not entirely clear why that was done, but that was part of eligibility for the trial. And I think that sort of muddies the waters a little bit as well, particularly when you start treating patients in the real world setting. And then, of course, shouldn't contemporary trials, now that we have an approved liver-directed therapy, we have an approved systemic therapy, potentially another one on the way, should these now evaluate the sequencing of agents? I think this becomes even more relevant with the data that was just released earlier this week. This is a slide that you all have memorized by now because this is the third presentation. I think Dr. Hernandez had it. The genetics presenter, I apologize, I don't recall the name, but that was a fantastic talk. That had it, and certainly I've added it on here, but it's a very simplistic model of understanding uveal melanoma, the location, what exactly constitutes the apparatus, and what are the risk factors. So I won't belabor that point in any more detail. So as a medical oncologist, we treat patients with metastatic disease. And what I primarily do is cutaneous diseases and obviously melanoma, regardless of where it starts, so uveal included. Our goal is overall survival across the board. We want our patients to live longer, and not simply longer in a quantitative manner, also quality. I think that becomes important, particularly when you look at the toxicities that a lot of our treatments unfortunately have. So if patients live longer, and the FDA likes that endpoint of overall survivorship, that is an appropriate endpoint for approval. What if overall survivorship is not a possibility to assess quickly? For example, in breast cancer, in advanced breast cancer, we have a multitude of options. And sequentially, each option offers incremental benefit in terms of survivorship. But if we waited for overall survival, it would take way too long for those trials to be done. So we look at what's called progression-free survival. So for how long does it take for a certain volume of disease to go from A to B, B being bigger than A? And then, of course, we look at response rate. We want our tumors to shrink. We want them to eventually go away, as is seen on the far right. And are we able to do that for any of all these in uveal melanoma? This is a timeline for regulatory approvals in the US for the treatment of melanoma metastatic disease or advanced unresectable disease. Regardless of where this started, the vast majority of these are for cutaneous disease. If you go back and see, in 1975, dacarbazine was the only drug that was originally approved. For over 3 decades, we had nothing else. Several of us, Dr. Lutsky, myself, I think are senior enough where we remember high-dose interleukin-2, and we did that, and that was a tough regimen. But it allowed patients with advanced melanoma and advanced kidney cancer to have complete responses. It completely disappeared, but only a few patients could get that treatment. And then the floodgates opened. I always look at 2010 as the watershed era. And then all the drugs that have come after that, everything in green is immunotherapy-based. Everything in red is targeted therapy-based. And then, of course, you have the one purple standing out, which is melphalan PHP, because that's neither immunotherapy nor targeted therapy. So melphalan PHP, and then back in 2022, tebentafusp, are the 2 FDA-approved options right now for patients with advanced uveal melanoma. And then in 2024, lifileucel, or tumor-infiltrating lymphocyte therapy, was approved for patients with advanced cutaneous melanoma, but is also showing benefit or has some data to support it for uveal melanoma as well. I wanted to highlight the 2, or at least a major difference between uveal and cutaneous. And this is an old slide, but I think it's important to understand it a little bit, because this essentially looks at the correlation between what is referred to as the tumor mutational burden, i.e., what are the median number of coding somatic mutations per megabase, which is down on the x-axis, how many hits at a molecular level does each tumor have relative to the objective response to anti-PD-1 therapy on the y-axis. And on the top, you see with the red arrow is routine melanoma, cutaneous, which is typically a UV damage signature, high mutational burden, and therefore, theoretically, a high number of neoantigens that can potentially be recognized by the T cell. And so response rates to single-agent anti-PD-1 are roughly about 35 to 40%. Other diseases that I treat, Merkel cell carcinoma, cutaneous squamous cell carcinoma, very high, again, UV damage. But you contrast that to uveal, which is at the bottom left, where there are very, very few somatic mutations that are identified, and therefore, drugs like pembrolizumab and nivolumab have essentially 0 to 5% response rates because these are simply not recognized as being aberrant or abnormal cells. And so essentially the bottom line is cutaneous and uveal melanoma, while they share the term melanoma, they're actually very different diseases. And we have to treat each one of them on its own merit and not simply say, because this worked in cutaneous, therefore by default, it needs to work in uveal as well. That simply does not happen. And the example in case in point is the seminal trial in cutaneous melanoma was Checkmate 067 that looked at combination ipilimumab plus nivolumab for advanced disease therapy naive patients. Response rate was 58% to that combination. And at 10 years, this is the longest data that we now have, at 10 years, 43% of patients were alive. If you contrast that to the pre-2010 era, less than 10% of patients with advanced cutaneous melanoma made it out to 5 years. So big difference, significant improvement. But you contrast uveal melanoma to that, the response rate to combination checkpoint blockade is between 12 to 18%. And based on the press release from this week from IDEA's phase 3 trial, it was less than 10% on their study. So again, highlighting that these are 2 very, very different diseases. But what's still important is this. So this little cell is the T cell. Big cell is the tumor cell. And T cells can directly kill tumor cells. So therefore, a lot of what we try to do is try to figure out how can we reinvigorate our T cells? How can we sort of arm them so that they actually can make a difference? And that's where tebentafusp mechanism of action comes into play. As many of you have already heard, this is a form of an ImmTAC, which is essentially an immune mobilizing monoclonal TCR against cancer, TCR standing for T cell receptor. And at the bottom, you have the melanoma cell, and you have GP100, which is commonly overexpressed in melanoma. It's one of the melanoma-associated antigens, but it is expressed to the cell surface only with the help of HLA-O201. So this is basically HLA restricted. And then on top, you have the T lymphocyte, and all T lymphocytes have CD3 on their cell surface. That's one of the hallmarks for T lymphocytes. So what Tebi does, or tebentafusp does as an ImmTAC, it's a molecule that has a recognition for the HLA-A0201 through GP100. And on the other end, it has an effector molecule for CD3. So it's basically, in very simple terminology, brings the T cell close to the melanoma, the uveal melanoma cell. And then through that interaction, there's polyclonal activation of other T cells that in turn releases cytokines. And those cytokines, as I showed you in the previous video, essentially lead to destruction of the tumor cell, or at least control. But because these are polyclonal cytokines or polyclonal T lymphocytes, and a multitude of them with different functions come together, you do see cytotoxicity, you do see toxicity as well, which is typically the cytokine release syndrome. Very common that we also see, for example, with CAR T, but to a much, much milder extent. And that's manifest by fever, rash, sometimes nausea, headache. Most of these patients, it typically occurs early and then improves over a period of time. And this was a seminal trial that led to the approval of tebentafusp. Patients with advanced melanoma, over 300 of them, randomized 2:1 to receiving either Tebi, which is the top overall survival curve, versus best alternative or standard of care. The vast majority received single agent anti-PD-1 therapy. And the overall survival was clearly superior. At the same time, if you look at the bottom curve, which is called progression-free survival, that was, while it was statistically significant in favor of tebentafusp, one can ask the question, was that clinically meaningful? Realistically, when you look at the difference in median, it was about 15 days. But from a statistical standpoint, it was better. So what does that tell you? It actually tells you something with bullet point 1, that while the overall response to tebentafusp is very modest, only 11% clearly meet criteria of tumor shrinkage greater than 30%, 35% have stable disease, which means the disease is under control. It neither increases nor decreases. Many patients had some shrinkage, but it didn't meet our pre-specified criteria for tumor shrinkage based on what's called RECIST criteria. So lack of tumor shrinkage is not necessarily bad news. So our patients often ask us, Doc, my tumor didn't shrink. And I tell them that's okay because it's not growing either. So you have what we call stable disease. In some ways, your tumor is living in harmony with the treatment that we are giving. And as long as that continues and you're tolerating it well, let's keep going. Side effects are common. Patients need to know that, but they occur early and they predictably decrease over successive treatments. So we have to be patient. You have to tell your patients you need to be patient, literally. And at the same time, physicians have to be patient with that as well. Interestingly, some patients will continue to benefit even if the scans show progression. And this was a post hoc analysis that was done on this trial where patients, even though they had progressive disease on imaging, if they were tolerating treatment well, they could continue on therapy. And those patients actually did derive overall survival benefit. So there's some, but that's not for everyone. So that's where I look at the art of medicine. Which are the right patients that we should continue treatment? And I think more exciting is looking at biomarkers, that if patients have clearing of their circulating tumor DNA, which occurred on this study, 60% of patients had a positive ctDNA at baseline. And a fair number of them actually by week 9 had cleared their ctDNA, so it became undetectable. Those patients actually had 3 times increase in their overall survivorship, 30 months versus 10 months if they didn't clear by 9 weeks. So I think you can detect early which are those patients if you're following serial ctDNA in these patients. So there's a lot to learn from this large trial where a lot of good things were done. Switching gears to combination checkpoint blockade, we briefly mentioned Ipi-Nivo, again, a common combination for cutaneous disease. And there were two prospective trials. On the left is the MD Anderson trial. On the right is a Spanish GEM study. Both fairly small studies, total 84 patients or 85, 87 patients in both. Response rates between 12 to 18%. And again, modest progression-free survival and overall survival ranging from about 12 to 19 months. But this is a toxic regimen. Do I use it? Absolutely, I do, because I know how to use it. I know how to manage toxicity. We've been doing this for 10 plus years. But it is a toxic regimen, and it's not necessarily for everyone. And by default, and I always look at this as physician bias, is we say that's the regimen we will use for patients with bulky disease without necessarily sort of thinking through that's what we normally do for cutaneous, and they respond. But in uveal, that response is far, far more modest. Dr. Lutsky led the nivolumab relatlimab study, which now the correlative science is being reviewed as well. Nivo-Rela is a far better tolerated regimen, but response rates, as you can see here, again, very modest, with an overall survivorship just about 1 year. So it'd be really interesting to see from Dr. Lutsky the correlative science in that trial. Maybe there's a group of patients that actually benefits from Nivo-Rela that we can certainly utilize from them. This was exciting. This was what is called PRAME-directed TCR therapy. Again, a very small subset of patients. PRAME is another antigen. It's referred to as a preferentially expressed antigen in melanoma. This is a form of cancer testis antigen. So we all have this when we are in the embryo form in our mother's wombs. But then as the baby is delivered, this antigen essentially disappears. See? But in selected tumors, including uveal melanoma, it reappears. It's highly expressed. And so again, this is in the form of small peptides in the melanoma cell. And through HLA restriction, these peptides come to the cell surface, and you can actually develop a TCR, T-cell receptor gene therapy, which is basically here Anzu-cel or Anzu-Tres gene autoleucel from Immatics. And this was shown last year at ESMO in a presidential symposium. So they had PRAME-positive solid tumors. There were 33 melanoma patients. 16 of those were uveal melanoma patients. Most of them had prior tebentafusp for liver-directed therapy. And basically through leukapheresis, which is essentially filtering out lymphocytes from the blood, they generated within 2 weeks their PRAME-targeted therapy, gave patients lymphodepletion to sort of knock down their native immune system, specifically the Tregs or T regulatory cells, and then gave them one solitary infusion of autoleucel, followed by subcutaneous interleukin-2. Almost every patient had toxicity. This is very common. Cytopenias are essentially 100% because of the lymphodepletion, but very impressive response rate, 69%, confirmed with 67%. 2/3 of patients clearly demonstrate RECIST affirmed responses. Duration of response almost a year, and median overall survival was not reached. And this is is anticipated to go into phase 2 expansion. So I'm sure a lot of data still to come. But again, goes back to that cartoon in the video that T cells are critically important in trying to help control the disease. What about the molecular pathway that leads to the development of this disease, which is the G-alpha pathway? We've discussed this before, GNA11, GNAQ, and a couple of others as well. And then the second hit that comes with BAP1 or SF3B1 or IFAX. And essentially what that does is it upregulates signaling through the MAP kinase pathway through either PKC, protein kinase C, or a variety of others, including YAP2, which is yes protein, or the PI3 kinase pathway. And bottom line is all of that eventually leads to cellular proliferation. So this was the OPTIM-UM01 study, which was darovasertib, which is a select PKC inhibitor in combination with crizotinib. So you may say, why crizotinib? One of the mechanisms of resistance to drugs that are targeting PKC is through MET signaling. So crizotinib is a MET inhibitor. So this trial combined the two of them, and these are oral drugs, easy for patients to take, but it does have toxicity, as I've listed here. The response rate in that phase 2 study was 34%. And median overall survival was just presented a few months ago at the SMR meeting of 21 months. So very impressive results for a smaller study. And then they went ahead and did a phase 3 trial where patients were randomized to Darocris as the experimental arm versus standard of care, and essentially just released this Monday, April 13th. The primary endpoint, statistically significant improvement in PFS for the Darocris arm of 6.9 months compared to the standard of care arm, which is 3.1 months. The nice part about this study was 75% of patients on the standard of care arm got ipi/nivo, because the tebentafusp trial was criticized because the vast majority of patients got single agent anti-PD-1, and we know that doesn't really work. Maybe ipi/nivo works a little bit better, again, modest, but the response rate here, even for ipi/nivo, was less than 5%. But this was a 58% risk reduction. You can't argue with that data. So this will almost invariably lead to FDA approval, but again, this is for HLA-A*02:01 negative patients. So therefore, that begs the question, in an HLA positive patient, should they get Tebi first and Darocris after that if it does get approved and we use it off-label? Obviously, we don't know what the FDA will eventually do, but this is very encouraging news for our patients that we will likely have a second systemic agent that will be approved, hopefully in short order. One last slide on some novel work that we are doing in Moffitt. This is targeted alpha radiopharmaceutical therapy. So again, trying to recognize tumors and their signatures. So this one is looking at targeting MC1R, which is the melanocorticotropin 1 receptor. This is on the melanoma cell. Over 94% of uveal melanomas express this. The active drug here is a radiopharmaceutical, which is actinium-225. We bind that with an MTI targeting ligand, and then that recognizes MC1R. And this is given intravenously. So we did a first in human study, 16 patients. The trial is completed. We presented some very preliminary data at ESMO 2024, and we hope to present some more data at ASCO this year as well. And so essentially, to summarize, I think frontline treatment for advanced uveal melanoma has clearly evolved with HLA stratification. So if a patient is HLA positive, A*02:01, tebentafusp is the appropriate treatment. People will argue that if there's bulky disease, rapidly progressive disease, maybe we should give them ipi/nivo. I'm not that convinced that ipi/nivo necessarily is a better treatment choice compared to Tebi. If they're HLA-A negative, I anticipate that darovasertib plus crizotinib will become our de facto new standard of care. Right now, it is immune checkpoint blockade for these patients. I think as Dr. Perez highlighted, combining liver-directed therapy with systemic therapy, a la Chopin, and hopefully we will show that with tebentafusp as well, is feasible. And prospective comparative trials are certainly needed. And I've always liked this quote. I read it in the Reader's Digest years and years ago. Essentially, life depends on the liver. And this actually came from an American philosopher and psychologist during a speech at Harvard that he gave. This was William James in 1895. And there the question really was, is life worth living? And his quip back was, it depends on the liver. And this, in uveal melanoma, I think it really amplifies that, because here, everything we do, we have to control the disease in the liver one way or the other. There's extrahepatic disease, but I think if we are able to control the disease in the liver, I think we will do well for our patients. So this is a team. None of this work is possible without a nice team to work with. Dr. Smalley leads our Center of Excellence. He's a PhD scientist. He's doing all of the correlative work on Dr. Zager's and Dr. Perez's tebentafusp PHP trial with those biopsies that we are doing. Dr. Tarhini is my partner in clinic. He's running a couple of clinical trials. Dr. Kareth has just published work on the first mouse model that really recapitulates uveal melanoma development and progression. Most of the prior models were either transgenic models or immunodeficient models that really don't capitulate human uveal melanoma. He's been able to construct that mouse, so hopefully we'll use that for some more translational work. And then we've done several clinical trials. At one point, I think we were the only institute that had 5 IITs, investigator-initiated trials. And then Dr. Morse is the inventor of the MTI-201 radioparticle therapy. Dr. Al-Haddad works with us from nuclear medicine. He's a world expert in radiopharmaceuticals and led the trial that led to the approval of lutetium for gastropancreatic neuroendocrine tumors. So thank you for your attention. I'll be happy to take questions.
So I have a couple of questions here, but we also want to allow the audience to ask some questions if they want after those presentations.
I have a question really to all the wonderful physicians and researchers that we have listened to. With the uncertainty in federal funding, how risky is it at this point for our disease? Have you felt reverberations coming that your grants that you have and you probably won't see anymore? Or are you going to other foundations? How are we going to continue this research?
And I'll welcome comments from others as well. We are definitely concerned. In the current funding environment, there's definitely been significant decrease in funding from the NCI. We're seeing far less R1s that are being funded right now. That being said, I think with patient advocacy, that is always ongoing. And more recently in March, this was right after the MRA meeting, which was in Washington, D.C. The very following couple of days was sort of the advocacy week in Washington. I know we had folks from Moffitt up there. We have folks from Moffitt who go to Tallahassee for continued funding from the state as well. And at least last year, there was no decrease in melanoma appropriation funds from the CDMRP, which is a congressionally derived funding for melanoma research. And within that group, there is a rare melanoma effort as well for funding. And that was also preserved. I know that because I chaired one of their DoD grant sessions. Now, for the future, I don't know what that holds. That being said, I think there's so much more awareness about uveal melanoma now compared to what it was probably previously. And I think that can only be beneficial. So keep doing the work that everyone's doing.
Thank you.
First of all, as a layman, this is so impressive, everything that you're doing and all the different trials. It's just overwhelming to imagine all that's going on. I just wondered, as I was watching this, is this only beneficial to uveal melanoma, or is this beneficial to melanoma in general or other cancers as well? All this work.
So I think a lot of the work that we've shown here today, some of it is specific to uveal melanoma. So for example, tebentafusp, but tebentafusp is now also being looked at in trials in cutaneous melanoma, because that's not exclusive. GP100 is a fairly ubiquitous protein. It's basically HMB45 that's expressed on melanoma cells. Similarly, the PRAME TCR, that target, the way they're doing it is more specific for uveal melanoma here, but there's a separate called the SUPREME study, which is also ongoing actually ahead of this trial that's already going on in cutaneous melanoma as well. And PRAME, for example, is a target that is expressed in other cancers, including uterine cancer, uterine sarcomas, mucosal melanoma. So I anticipate that we will continue to see expansion of this for other targets or other diseases as well.
Thank you.
I have to say, Bill's Mafia for life. So, yes.
For the PHP, why the booting people out if they've got extra hepatic disease, and what's the threshold where you're like, oh, that's too much, we can't treat you anymore with PHP?
Yeah, it's for extrahepatic disease, it's a little bit subjective. It depends on whether or not the disease can be adequately treated with a local or regional therapy outside of the liver, safely in between PHPs. So with either stereotactic radiation or even a surgery, as we talked about. So I think typically, I would use like more than 3 lesions. You start to kind of think, not necessarily, I don't ever close the door on PHP in those patients either. I just say, maybe we try something initially, and if there is some disease stability outside of the liver, then we can go back to liver perfusion.
So does the PHP affect those other possible treatments? I mean, does it interact in some way that makes that, undesirable?
Does doing PHP first affect?
Well, if you're in the middle of doing PHP, and let's say, as an example, I haven't had liver tumors in 6 years, but they could show back up. But I've been treating brain tumors left and right.
Mhm.
Sometimes they show up as 3, sometimes 10 or 12 or 14 or whatever, but they've all been treatable. And so does the PHP. If you're doing PHP, would that say, oh, well, then you don't want to do a gamma knife on your brain because the PHP is going to upset it or whatever?
Yeah, that's good. I get your question. It's we need to make sure when we're doing PHP and other therapies that we time them to where one of them doesn't lead to adverse events with another. And so with PHP, for example, the patient is anticoagulated systemically during the procedure. So you want to, if you're doing any procedures in between, you want to make sure that you're not setting it up to where they're at increased risk at their next PHP for a bleeding event or something like that. But overall, as long as the treatment in between PHPs is done in a manner that it does not put them at increased risk for the next PHP, then we're able to combine these therapies.
And I think we have a little bit more leeway now that PHP is approved and we have other treatments systemically as well. So going back to sort of the example that you gave with brain metastases. So if I had a patient who has liver dominant disease and is in those 6% of patients of uveal melanoma that also have brain mets, then I would treat the brain mets first because you want the brain to be under control. And then the PHP can come in after that because of what Dr. Perez says. If we gave that patient PHP right up front and they drop their platelet counts to less than 50,000 or 30,000, they are at extraordinarily high risk of bleeding in the brain. So you want to address the brain first and then come back to PHP. And that sort of is where I get to, as a multidisciplinary team, it is not just Dr. Perez's decision or my decision or the radiation oncologist's decision. I think as a team, we discuss these cases. And therefore, this is a rare enough disease where I think patients ideally should seek opinions at centers like, at the University of Miami with Dr. Lutsky and his team there and Dr. Hernandez, or Jefferson or Moffitt or Jacksonville is certainly part of that team as well. So I think at least getting an opinion and trying to sequence it in the right manner, and then maybe the treatment can be done closer to home. We have many patients who come and get their first 3 tebentafusp treatments with us because we have to observe the patient for 16 hours post-treatment, so they'll end up getting admitted to the hospital. But then beyond that, I tend to get them back to their home oncologist, which may be in Sarasota or Fort Myers, because Tebi is a weekly infusion.
And I think the exciting thing outside of the clinical trial with any of these liver-directed therapies is that you can always, not always, but you always keep the door open for going back to something. As Dr. Kushlani mentioned, life depends on the liver. If somebody comes off of a liver-directed therapy and they get on systemic therapy and they do well on the systemic therapy extrahepatically, but the liver disease starts to progress again, there's no reason why, us as providers should be like, well, we tried it, we move on, right? We keep a good, close communication with our colleagues. And at any moment, if it makes sense to come back and return to either whether it's PHP, Y90, chemoembolization, we certainly, that's the multidisciplinary aspect and the art of it.
Which, by the way, there was a House episode where he discovered some problem with somebody's liver. He said, it's pretty important. It's right there in the title of the organ.
Hi, I'm curious what you guys think about TIL and CAR-T as future treatments for uveal melanoma, and specifically for people who are PRAME negative. I know I've seen some research about them doing stuff for PRAME positive and targeting PRAME, but is there anything they can target if you are PRAME negative?
So first question in terms of TIL, the answer is yes, there have been trials done. I think from the centers around the country, the University of Pittsburgh has been sort of the dominant force for TIL. Dr. Kumala there has led a phase 2 trial. The response rate for TIL is about 33%, give or take. For those of you who are not as familiar with TIL, essentially is we actually harvest tumor, we take it out of the body, and in the laboratory, we expose that tumor and the lymphocytes in that unique tumor of that patient to IL-2 or interleukin-2, which is a cytokine that stimulates those lymphocytes. We grow those lymphocytes to the tune of billions of cells, and then we bring the patient in for chemotherapy, very similar to what I showed you with the PRAME TCR study, and then give them those TIL back. That's a tough process. It requires a lot of things to fall into place, and including adequate site for tumor harvest. That becomes really important. And a lot of these patients, for example, liver-directed therapy, they've already seen liver-directed therapy. Then you ask yourself the question, is the tumor that we derive from the liver, is there going to be adequate tumor there, or is it just all necrosis or dead tissue? We may not grow lymphocytes. Now, Dr. Kumala's group has actually shown they can grow a fair bit of lymphocytes from those tumors as well. But he's gone one step further in a very eloquent manner, demonstrated that specifically increasing what are called tumor-reactive lymphocytes. So these are lymphocytes. All of us have lymphocytes that are there everywhere, essentially. In the tumor, not every lymphocyte that is there is recognizing just that tumor. They're there for other functions too. But his group has shown that if you specifically select out and grow the lymphocytes that recognize the tumor, those patients do even better. So I do think there's a future for TIL in this disease. Where exactly it falls is going to be hard to say. So at Moffitt, our ongoing TIL trial, which is a CD40 ligand study, does permit uveal melanoma as well. It's mainly for cutaneous, but uveal is also permitted. So I do think we'll see more data on that. Yeah. Specifically with CAR-T, I think that's an active area of research in terms of trying to develop CAR-Ts that may be very specific to uveal. One of the problems, unlike heme malignancies where CAR-T has really revolutionized everything, our tumors tend to still on the solid tumor side be more heterogeneous. And so there may not be one specific driver of the tumor. As you can see in uveal also, there are multiple hits that occur. And so we may not necessarily have the specific CAR that only recognizes a uveal melanoma cell and nothing else. I don't know, Jose, if you want to add anything to that.
This, yes, still as kind of TIL that we do gains melanoma, because as was mentioned before, very low for uveal melanoma, so that generates fewer antigen, fewer evidence. Therefore, the types of infiltrating T cells that are in the tumor, it's not going to be as much variability. Cutaneous melanomas are lots of antigens and a lot of.
Okay, is it better now?
I didn't say anything, but I could hear you clearly. I didn't realize I could hear it.
So what I was saying is that the main difference between uveal melanoma and cutaneous melanoma is the lack of mutations in uveal melanoma in fewer antigens that would be targets for the ST-reactive cells that Dr. Kushlani has mentioned. So we haven't seen the kind of success with TIL, unmodified TIL. There are some trials the trial that you mentioned from the University of Pittsburgh initial trial showed a 20% response rate, but we suspect that some of those patients were selected patients that maybe had better immune system, patients that had extrahepatic disease that are sort of self-selected for better response to immunotherapy. Now, Dr. Uday has found a surrogate marker, perhaps, that may allow us to select the people that are more likely to respond to TIL. But my view, I think, PRAME-directed TCRs that was mentioned, we treat a lot of those patients with that here. I mean, we have seen amazing responses. The question is the durability and the toxicity. Right. That would be cell therapy. For cell therapy specifically, you're asking? Yeah. I mean, we have to find other targets, or we have to select patients that would respond for TIL, or ways to perhaps overcome the immunosuppressive environment of the tumor.
I think we have one last question in the audience.
Hi, thank you very much for the talks. I thoroughly enjoyed them, and thank you all for the patients and their families for being here. It's a very heartfelt event. My question specifically is about PHP therapy. It seems like it's shown great promise for patients who have liver mets. Like with anything in medicine, there's risks and benefit calculations. Was there any consideration of potentially like an adjuvant type of either a low or medium dose therapy for high risk uveal melanomas before even they metastasize to have them undergo PHP, such as like class 2 type of mutations?
Yeah, I mentioned in one of the previous talks was there has been some, discussion and some theory about, using liver perfusion in the adjuvant setting. And so that's not something that, we haven't done it yet and shown, have data to support it yet, but it's certainly up there in the potential for, adjuvant therapies. The thing with adjuvant therapies is when you're treating a patient in the adjuvant setting, the risk benefit profile is a lot different than treating patients with active metastatic disease. And so, you want to make sure that when you're selecting these trials and designing these trials that you want to make sure that you're, really focusing on, all the risk benefit of the disease treatment.
All right. Thanks so much for a wonderful session. We are now going to call up our panelists to talk about clinical trials and innovation in treatment. So Dr. Lutsky, Dr. Hernandez, Dr. Sabula, Dr. Marr, please come on up. And Dr. Di Nicola, we'll have you moderate.
All right. Well, thank you everyone for such amazing talks and really great discussion. So a lot of the, some of the things that we are planning on covering for this panel have really been discussed through, the presentations. And so I'm just very happy to welcome back to the stage our, Drs. Marr, Sabula, Hernandez, and Lusky. So, we've heard a lot about options that we have out there, clinical trials, possibilities. And as some of our speakers mentioned, up until 5 years ago, we wouldn't have been having this discussion. It would have had a free afternoon because we wouldn't have had much to talk about. So I have some questions here, maybe taking a step back. And, Dr. Lusky, you've done an amazing job at outlining the different, along with Dr. Kushalani and others, the inclusion, exclusion criteria of clinical trials. But I want to ask you and Dr. Hernandez, when you are consulting some of the patients that we send your way that are high risk for metastatic disease, what kind of conversation do you have with them when you kind of open up to the possibility of clinical trials? How do you identify what patients are best suited for clinical trials? What are some of the considerations that you keep in mind when starting that conversation?
Was it Dr. Hernandez? Very important question. And I alluded a little bit about that in my talk about when we talk about the risk factors and the gene expression profile results. If we have a high risk of recurrence, and as was discussed earlier, the candidacy of that patient for the study makes sense, right? You have a very aggressive disease that can come back. So I think right now we don't have an approved therapy. So it's only in the context of a clinical trial where that particular patient can have access to a potential beneficial drug in the future. So we discuss about the risk of the recurrence and also the risk of the therapy that we are talking about. So in adjuvant trials, frequently we want to see, drugs that have shown some preclinical data of, working in uveal melanoma. We want to know the toxicity so we can, discuss that risk benefit. So so I think it's taking into account the patient's factors with the other comorbidities, the tumor factors, and also the therapy that we're about to offer, if it makes sense for that patient.
Those are all excellent points. And Dr. Mara, I want to hear your opinion, because whenever it comes to eye-specific clinical trials, we don't have as many things to discuss as our colleagues in medical oncology do. So really, mostly we're offering, the AURA trial. So very different ends of the spectrum, right? Like AURA trial for very small melanomas, indeterminate lesions, or neoadjuvant darovasertib for very large lesions. And just so that we're all on the same page, when we use the word neoadjuvant, it was what you were asking this morning, John, something that we can do before a definitive treatment. That could be radiation of some sort to try to shrink the tumor down, decrease the size, so that we can offer other options afterwards. So how do you approach those conversations? What, in your mind, what are the ideal patients? And when I'm asking this, I'm also thinking about, for instance, some considerations with the AURA trial. It's very intensive. It requires many treatments. It requires for the patient to come many times to your clinic, spend a lot of time. And there's also a placebo arm in that trial. So how do you navigate all of these considerations when you're counseling patients about these trials?
So it's partially determined by the inclusion criteria. So one end of the spectrum with the AURA trial, you have to have a small lesion that has documented growth in some way. And on the opposite end, you have to have a larger or a tumor that either is big and is going to get a nucleation, or is a certain size and we want to avoid radiation. So in the back of my head, when I'm looking at a patient before they even know what's going on, I'm thinking, well, what are my options? Do they qualify for this study? Because if they don't qualify for the study and we say, oh, you could have the study, but you don't qualify, it's kind of disappointing. And so you don't really want to dangle a carrot that they can't have. So from that standpoint, I make that decision. And then I go through just basically what I talked about before, their goals in treatment, what they want out of it, what's available. And then, the whole process of time, possibilities of success, side effects, and then we make a decision. Mm-hmm. And it's different stories on each side of the spectrum, because one is all about vision and the other one's all about lack of toxicity.
Mm-hmm. Yeah. And so speaking of toxicity, Dr. Lusky, you see a lot of patients that undergo clinical trials. And so I'm sure you see a lot of, toxicity that could be a little bit of a limitation to these studies. Have you been able to identify any other limiting factors? What are some of the reasons why you think some patients can't enroll in clinical trials? Is there anything like from a geographic standpoint or support standpoint, caregiver availability, any of those things come into play when you're kind of considering this options?
Yeah. Well, I think, there's several factors, right, to determine whether someone would be eligible for a clinical trial, just beyond the eligibility criteria themselves. So if you look, for example, one of the things I think is hardest to figure out from the get-go when you first see a patient is sort of the tempo of the disease. And if you want to tailor your clinical trial with an agent that, if someone's progressing very rapidly, an agent that will work rapidly, do something like PHP, or rather than an agent like tebentafusp that may take time to work and may be actually difficult in the beginning to figure out if that patient is going to do well or not. Because we see a lot of patients coming from elsewhere here, that is another issue, the ability of patients to get here for treatments. Trials with tebentafusp for patients that don't live here is particularly difficult. It's a weekly treatment, and it's hard for people to get here. So support systems are very important. And I think there are a number of social issues also sometimes that get in the way.
Yeah. Well-
I don't know if Dr. Hernandez has additional
Yeah, no,
factors that he considers.
I was just gonna mention that for for example, cell therapy, we have to monitor those patients after the cell therapy or, either TIL or the TCRs. We have to monitor them very closely after their discharge. So we frequently recommend that they stay within, a close, range from the hospital because of the risks of side effects. And, so I think it's, again, when we're discussing a therapy, it all looks, very exciting and promising, but we have to take into consideration, many other factors for each patient. But again, I think the fact that we're talking about this is great for patients and families, because now we have, all these possible, trials so that we can, enroll our patients in, so we can, discuss and my comment about surveillance, again, it's, I think it's important because if you're doing your scans regularly and there is something small that we find in those scans and we prove that is metastatic disease, that's when we can start looking into options. So we have more time to make those decisions when the disease is small and, patients can travel. If there is a good trial at Moffitt or here or in Pittsburgh, then patients can go and do those trials. But if the disease is diagnosed at a later stage, more, majority of the liver is involved in those situations, then the options are limited and we don't have that time. So I think, again, surveillance, doing the gene expression profiling, following, is very important.
Yeah.
Quick comment. So to put things in perspective, I think, we talked about our surveillance, and it seems like our technology for prognostication has excelled in our ability to treat things. And that's why there's a little disparity. And when we first started doing prognostication with gene expression profiling and BAP1 detection, we could determine high-risk groups, but then we didn't have anything, zero, to do about it. And it put everybody, the patient and us, in an awkward position. But today we just had at least 5 to 7 adjuvant trials that are available and open. And this is a huge difference from when we first created these prognostication tests. And I just, from my own experience, seen the tempo growing in this is very encouraging. So I think, these options of trying to get to different places are a good problem to have, because before we didn't have anywhere to go to do it.
Agreed completely. And just as a reminder, I know that the MRF team reminded you all this morning, but there is a clinical trial finder tool that they have available in case you're interested. Well, I want to move on to, we've already tackled some of this topic, so I want to move on to a couple of more innovative things that I'm sure a lot of people in this room have heard about. One is liquid biopsy, and then I want to touch upon artificial intelligence a little bit for the end of this panel. And so just again, so that we're all on the same page, what are we talking about when we talk about liquid biopsy? So you've heard a lot about tumor biopsy, biopsying the tumor inside the eye, or biopsying the tumor in the liver. Those, of course, are invasive procedure. You have to go in the eye, in the liver, to get a piece of tissue and analyze it. In a way, liquid biopsy is a non-invasive way of getting information about cancers, because you're analyzing fluids in the body, whether it's saliva, urine, or more easily blood, to see if there's any sort of cancer-related material, whether it's cells or DNA. And so that kind of lets us know a little bit more about the tumor. It can give us personalized treatment information and so on and so forth. And so when it comes to the eye, a lot of work has been done for retinoblastoma, which is a child pediatric cancer, but there is some work now being done for uveal melanoma as well. And so, Dr. Sabiola, I know that you're doing, some research in this field as well. Can you give us a little bit of an overview of you know,
Yeah,
what?
I would just say, I think this is a really big future area for ophthalmology or ocular oncology, because I think, you know, in terms of the eye, the aqueous humor or the front of the eye, we can just remove a tiny bit of fluid very easily, perhaps in the office or at the time of an eye surgery. It's very, very safe. And then we actually find, you know, there are proteins or perhaps DNA that we can evaluate that can tell us what's going on inside the eye, and maybe what are some targeted pathways or, you know, things that we could then work with our medical oncologists to better, you know, treat the eye, or maybe see, is this a high risk melanoma versus a low risk melanoma. So I think we'll be able to, instead of having to biopsy the actual tumor tissue, we hope that in the future we'll be able to just take this very not, you know, less invasive fluid sample from the front of the eye and get some of the same information with a less risky approach. And then maybe also like have a research arm that will find the, you know, the targeted therapies. So this summer, our whole department, we're trying to get a project going where we'll actually take a lot of liquid biopsies, have this bank, and, you know, do a proteomic project. So that's thanks to Research to Prevent Blindness. So shout out to them. But yeah, I think this is going to become very exciting area of future research that we'll learn a lot in.
Yeah, it's definitely exciting for us to be able to offer to you all more information about the tumor that without necessarily exposing you to risks related to those procedures. And we heard earlier from Dr. Kushalani about how circulating tumor DNA, you know, can drop in response to tebentafusp treatment, even though maybe the size of the tumor is not necessarily shrinking. So I'm curious to know, Dr. Lasky, Dr. Hernandez, what do you make of that? What are we learning from that? Like, what is that telling us about the biology of the tumor, if anything? And I know it's a difficult question to answer because we're, you know, I guess speculating for the most part. Or Dr. Kushalani, if you have any input, would love to hear from you as well.
Yeah, no, I mean, I think it's great that the clinical trials are now incorporating, you know, ctDNA into the correlative, you know, part of the protocol, and also, you know, because we can then analyze that data and see which patients, you know, are responding early, like they did in the tebentafusp trial, and like it was mentioned, you know, some we're learning, you know, from how the T cell and the T cells are eradicating these cancers, and that doesn't happen like we're used to, when we were just given like a chemotherapy agent and that we would see the tumor shrink, you know, after a few weeks of therapy. In some cancers with the immune cells, it's different. Sometimes the tumors look larger in the first scan, and we don't know, is it working, is it not? The scan looks a little worse, but the patient is feeling well. So there are some situations like that where ctDNA, a blood test that we can do, you know, sequentially and periodically, if we see that maybe the scan looks a little worse, but the ctDNA levels is going down, then we feel more comfortable continuing treatment for that particular patient. So again, it's part of the information that now we have and we're using in the clinic to make decisions, and you know, especially with tebentafusp, it is very important because as Dr. Kushalani said, we don't see the response rates are only 9 to 11%. So we don't see a lot of tumors shrinking, but we see patients feeling better. We see them, you know, continuing living their lives and, you know, working. And so again, even though the tumor is there, we see it, the ctDNA levels are going down, they're feeling well, we feel comfortable continuing with the treatment.
I also think that the specific test that you're doing matters a lot. When in the tebentafusp clinical trial, they created a set of primers that were specific for uveal melanoma. So when you look at those levels of ctDNA and you see them going down, you know, it was detectable in, I believe, like 50 or 60% of the patients. Now, the regular assay, the commercial assay, is not tailored for uveal melanoma. So I had patients that had massive amounts of disease and had a negative ctDNA test.
So I think it needs to be something that's tailored for uveal melanoma. The assay that we're using in our adjuvant trial is done at Dr. Harbour's lab in UT Southwest. And what he's doing is he's looking at specific mutations in the initiating mutation, GNAQ and GNA11. I asked him about BEP1, but it turns out that BEP1 has lots of mutations in different places, so you have to create lots of primers. But he's been able, as I show you, and has been able to pick up ctDNA in patients that have been treated. So that's the other thing. We don't know, I mean, at least I don't know, and maybe Dr. Marr here, someone knows, how long are these cells, not the cells, the DNA of these cells circulating after you give them primary treatment. Those patients that I showed you, there were months after primary treatment. So how do you interpret that? You know, if it's going down, if it's going up, if it's going down in that trial, for example, it could be because it's just the cells are dying and it's going down, or it could be because the drug actually was doing something to cells that micrometastases that maybe were there. We won't know until we follow these patients for a longer period of time. So I think there's a lot to be done still in that field, especially in uveal melanoma.
Yeah.
So that's one point I wanted to make and ask Colleen. I think that circulating tumor DNA and liquid biopsy for metastatic disease is a very useful tool and needs tailoring. But what do you think about intraocular use and using circular tumor DNA for intraocular before it metastasized? Are we at the point where we can make decisions for that? Now, personally, I don't think that's possible at the current, and I want everybody in the audience to kind of realize that it's very useful in the metastatic setting, but for trying to do the initial tumor, it may not be quite where we want it yet. And people are looking into that, and we're doing research to try to do that, because that would be nice to know, for local recurrences. But sometimes people will get confused looking for circular tumor DNA for a very small tumor or a primary tumor. And I don't think that we have the resolution, at least readily available, to make those decisions and what they mean if tumor DNA is found.
Yeah, I think that's a really good point, because I think from what we've learned, there are some tumors in the eye that you can detect more DNA, but melanoma you don't have a lot of DNA that's into the aqueous humor. So it's not going to be, like if you have, whatever mutation, you're probably not going to be able to detect it from the aqueous humor, I would think. But maybe there would be like some sort of signature of proteins that would be associated with a type of gene expression profile. Like that's sort of what probably more people think we would have success in that.
Right. And I'm not even saying from the aqueous, because you think the concentration would be much higher in the aqueous. I'm talking about blood.
Systemically, blood.
Right.
Yeah.
And so people are making comments about eye stats through blood.
Oh
And I
yeah,
just
from the
don't think-
primary, I don't think
I don't
so.
think it's valid, or at least not at this point.
Yeah, correct.
All excellent points. I know we have only a little bit of time left. I want to touch upon the last topic, and then maybe if we have time for a couple of questions, if there are any. AI, everybody hears about AI all the time, right? So just for people who might not be familiar with this in the room, there are some groups looking at, this morning we kind of discussed oftentimes the diagnosis of uveal melanoma is clinical. In other words, we look at the tumor, we look at imaging, and we decide if it's benign or malignant. Sometimes we will need a biopsy to confirm in indeterminate cases, but there are some groups that are trying to train artificial intelligence models by feeding them a lot of images of proven melanomas versus proven nevi and seeing if the machines are able to distinguish for us. Similarly, by getting that information, are we going to be able to determine with artificial intelligence what patients are better suited by observation alone and what patients would need treatment? And we've also talked about all of this prognostic information that we're getting from genetic analysis of tumors from biopsies. Again, are we going to be able to correlate that information for those patients where we have that information, where the biopsy has been obtained with their imaging, with the way their photos look, and is AI going to be able to predict potentially prognosis and even visual outcomes maybe? So this is a very hot topic when it comes to ocular oncology. I think you guys would agree. What are your thoughts on this?
Yeah, I mean, I think we don't know yet. I mean, I think it's something that would be really interesting to try. I know like several of our colleagues are working on this. So I mean, it's sort of like, you know, there was it, I forget what software company, you know, looked and said they can tell male and female from just from the retina photo. And I kind of wonder how is that real, number one. And then number two, like, wow, there may be something that it could detect, like some pattern that we just have no idea. But yeah, I think I mean it's really interesting question. So we'll see.
As Basil mentioned, we went to this international conference in Rio, and I think one of the things that I took away on the AI front, which there was a whole half day about, was that the NHS in England has kind of standardized some of their image acquisition to be able to be pumped into this data. Because you know it's a rare tumor, so to teach an AI model, you need lots of positives and lots of negatives. And when there's only 3,000 cases in the United States a year, and you need 300,000, you can do the math and see how long it's going to take to get something like that. And especially if you know you only have one doctor that does so many here, and then the other one does. So to do a big national thing like they were doing in England, I thought was very impressive to try to standardize the image acquisition and get the data for that. But I think looking at a genetic outcome and a visual pathway and the black box between it is amazing. We'll see what happens because I'm fascinated. If you could put that jump from a whole gene to a whole picture and know what's going on would be very impressive.
Yeah. I mean, there's so many artifacts too that they've mentioned that they learned about. Like, so like, I think one problem was like a certain camera at this one place, the one center, you know, it had, maybe they had more like advanced tumors at that location also. So it was just like somehow that something about the camera itself was like causing an artifact. So,
yeah. I mean, it sounds very promising, but I agree. There's definitely a lot more to be done and more research more effort that we need to put into this. Any questions from the audience? Yes.
I was curious. Nope, it's all good. You know, as patients for trials, I know when I did one way back when, kind of one of the motivations was get data out there for people to be able to use to make determinations. You know, this works, this doesn't work. In this case, it might work better, blah, 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 blah. And it just occurred to me that if you're in the unfortunate metastatic patient perspective, at some point, this thing's going to be tumor progression to the point where it kills you. Is it possible to do like organ donation of tissue that can, because I'm assuming it's hard to find tissue from existing patients. Can you take a dead patient and harvest a whole bunch of stuff that can be put into research to use for something? I don't know what, or if that's even usable.
So going back to the AI question, I saw in a recent conference, and it might have been one of the uveal melanoma conferences, that there were some scientists that are playing with creating sort of a virtual cancer cell, and in which they take a tumor and they sequence the genome and of the tumor. They get the DNA, the RNA, the transcriptome. They put it all in a database, and also put all the different biological pathways that may or may not be activated in that cell. So they create sort of a virtual cancer cell for that particular patient, and they can, you know, predict which treatments may or may not be appropriate. Now, whether that's going to turn out to be true or not, we don't know. We've had over the years several iterations of predicting chemotherapy, for example, and that didn't work. But I think we're a much more advanced level now, and this may actually work. I mean, other than that, we have to rely on our clinical experience. Some of it is gut feeling, and a lot of it is actually the data that comes from
sequencing, et cetera.
And I'll just also follow up on, so we are working, we have a initiative at Ohio State, it's this brain biobank. And so we also are adding on now, we're trying to add on to that, like, body donation, like when, definitely the samples from metastatic disease, I think is really critical because there's really not much of it. And so much of what we learn does come from the tissue that we have. I mean, so much of our BAP1 work, came from having a tissue specimen that we could double check. Is that mutation, important? So I think the answer to your question, I think, is really like, yes, I think that will really help make a difference. So part of the issue is like funding, like, so to actually, try to obtain the tissue and have programs like that, it really is hard to get funding for that. And especially this environment is extra challenging right now. So that's why we thank our foundations, they're so critical for, helping us with that kind of research. But yeah, so we have a way to do that so people can donate, their body or their eyes or things like that.
So we were able to do that when I was at Sloan with my former partner, Dr. Carvajal, where we had an autopsy and we were able to see the progression of different genes throughout the body in different areas. And that was very, very useful information. And that was probably a decade ago. The logistics of trying to make that happen made us never want to do it again, because in the hospital of all the different things to the way the regulations are of how post-mortem people are treated and what's regulations was very, very difficult. Hopefully that has changed, but it was we published a paper on it. It was very useful information. So I hope we can do more of it.
And especially learning how some treatments, what can we learn from like how a treatment worked on the tissue and things like that? I mean, I think sometimes you guys take a biopsy after a treatment.
Yeah. And sometimes, some of the work with the several mutations that develop over time is from those kind of studies where you take biopsies from multiple metastatic sites. And obviously in a patient doing multiple biopsies is difficult. So we don't, but if we can have multiple tumor types, multiple metastatic sites, it's a lot what we can learn about, escape mechanisms and what mutations are, driving resistance to the therapies that we're using. So.
This was a very stimulating conversation. Thank you so much to our panelists. Thank you for participating. We have an announcement.
Yes, you are welcome to go back to your seats. I released you back to the crowd. We're kind of wrapping the day up here, and I just wanted to take a moment to sincerely thank our experts here today. Your passion for this community and your passion to advance science and to ultimately continue to create treatments and cures to this horrible disease is so profound and moving. So I just wanted to sincerely thank you all for taking time out of your busy schedules and on your weekend to be here with us. So if we get a round of applause. Thank you. And many will be with us tomorrow too. So continue to find time to chat. As we're wrapping up here, I just wanted to let everybody know our final session for the day will be support group. So it's kind of a space to just check in with each other. So we're going to have a metastatic support group that will be with Miriam over here. Miriam, raise your hand. Thank you so much. And then I will be taking our caregivers. And then outside we have Abdi and Laura, who are two Sylvester social workers, and they will be splitting our primary group. So just taking a moment to connect with each other, and then we will have dinner at 6 p.m. sharp, if not a little bit earlier. And then we'll start the shuttle services back to the hotel for those of you who are here with us. But thank you so much for really just a wonderful day. I think tomorrow is going to continue the community and joy that we have in this space. So just thank you all for being here.